There is evidence that it is really low cost. There is evidence that it is high skilled, and there is it's a very high impact practice. And just now Somsekhar sir said, kangaroo mother care done very well for a low birth weight baby, and he connected that directly to the intelligence in adolescents. So why we concentrate only on this single maneuver or care, kangaroo mother care, is because it is evidence based, humane, low cost, high skilled, and high impact. This consists, kangaroo mother care consists of early. What is early? We'll discuss a bit. What is prolonged? We'll discuss. And continuous skin to skin contact between mother and the baby. And who are the other people other than mother? All of you know, most of you know. And exclusive breastfeeding will continue as much as possible, because different babies are there that consists of a serious other than high dependency NICU. It includes a serious hospital, a very big NICU to home. So breastfeeding as much as possible does not mean it is. That's why it is said exclusive breast milk feeding as much as possible. As much as possible is in the sense of the baby. Uh, Otherwise, we would call it whenever possible. Early discharge with adequate follow-up and support, and initiation of practice in the facility. And once it is practiced in the facility, how it should be continued, how it should be followed at home. Not writing in the discharge card that KMC, continuous KMC, it is not a this thing. It should be practiced in the facility for all babies who are eligible, and then how it should be continued, and this continuation, how it should be monitored, that we would discuss. Then kangaroo mother care method is holding the newborn, the low birth weight, or the preterm, or other indicated babies. It is not just only low birth weight and small for date babies. There are even term babies who require kangaroo mother care, we know. So how you directly hold them skin to skin contact of mother's chest in between her breast without any clothing, because mother's chest and baby's chest are both are naked. The baby's neck is extended. This is very important point. Baby's neck should not be flexed at any time when in the kangaroo, while kangaroo mother care is being given, and is as much vertical position of the baby as possible. Mother can be in any position that we are seeing so many pictures, so that mother and baby can have an eye to eye contact, a bonding develops, and both are covered from together from above. Otherwise, to simply say it is not a very science point, though it is a evidence-based, highly scientific program, scientific practice, simply it can be said that it is a loving body hug between mother and the baby, especially the small baby. Then there is something called skin to skin contact, which happens in every delivery, in every normal delivery, of course not a second. That is immediate early skin to skin contact after delivery, which is recommended for all babies, including the term babies. That is, you know, the breast call. This is to facilitate the breast call. Once the baby is out, after that small little drying is done, baby directly goes to mother's chest, and you cover with another dry towel and then maybe a very big bed sheet. When mother is on the labor cot herself, this is called skin to skin contact. This happens to about, though in India, because 60% of the babies are low birth weight, the skin to skin contact practice very routinely would facilitate the KMC for all babies that are required. Otherwise, we can say the skin to skin contact which starts at birth on the labor cot itself, on the mother's which facilitates breast crawl, and a continued KMC would be facilitated. These are not two different terms. These are different terms, but STSC is not that famous as the KMC. So if we know the skin to skin contact of every single baby, those babies who require, who are benefited by kangaroo mother care, it would be facilitated. So I again repeat this word: skin to skin contact and breast crawl for every baby. And how kangaroo mother care works? then neuroendocrine, don't bother how big science it is. There is something called oxytocin, all of you know. Oxytocin would be released by touch, light pressure, warmth experienced by the infant during skin to skin contact, during KMC and STSC, and while breastfeeding, how mother holds the baby. So when baby and mother are together, there is a release of oxytocin, and there is a central stimulation of the vagal nerve or parasympathetic nervous system. This influences the physiology and endocrinology of the infant to optimal growth and development of the baby. So this is the benefit, how KMC benefits the baby and mother. Then oxytocin released due to touch or other mechanisms leads to several benefits of temperature regulation, sedation or baby's calmness, and anti-stress effects. There is a cycle called sleep-awake cycle. Most babies sleep. They feed and sleep initial few days, and then it takes about 4 weeks for the baby to establish the baby's sleep and awake cycle. It takes few weeks for each baby to develop its sleep and awake cycle. And when kangaroo mother care is done and oxytocin is released, this sedation and awake cycle gets regularized or stabilized. This causes a lot of anti-stress effects. And that also temperature regulation is one point every one of us know. So it is not just, it is the mother's warmth that baby is getting. Due to KMC, a lot of physiology, a lot of neuroendocrine facilitatory mechanisms are happening. One is the sleep awake cycle. How many hours the baby would be awake, how many hours the baby would sleep, this would be established. We get, as pediatricians, as nurses, all of us know, mothers would complain the baby doesn't sleep, this baby is fussy and all that. So KMC is going to stabilize that. And this causes anti-stress. Right. Don't bother. There are so many arrows here. The skin to skin touch that releases the oxytocin. This works in multiple ways. The oxytocin has an analgesic effect, sedative effect, neurodevelopment and brain maturation effect, and this leads to the bonding. And oxytocin, the quiet alert state, the most of the babies, and a little thing I'll explain about quiet alert state. All newborn babies, for first half an hour, they are in a quiet alert state. That is, they don't, after their vigorous cry, they are quiet and alert. This is the time where to initiate breastfeeding. And after soon, this quiet alert state transforms into a very prolonged period of somnolence. That is, most babies would go to sleep for about 12 to 18 hours. And typically the family, what happens? That they feel that the baby is sleeping or baby is dull, and people start giving prelacteal feeds. And actually the baby gets up after this period of somnolence after about 18 hours to 24 hours. Then one starts, if the baby is lucky and mother is advised properly, she would offer her breast. And there is a popular belief in most communities that the breastfeeding stabilizes or starts on third day. The reason is we miss this quiet alert state of the brief quiet alert state of the baby to initiate the breastfeeding. That is the reason why we on all workshops would stress on the initial, within 1 hour or with the earliest possible, the initiation of the breastfeeding. All of us know that breastfeeding is the strongest stimulus for feeding. The baby suckling is the strongest stimulus for the initiation of breastfeeding. So each baby should not miss that the earliest period of initiation of breastfeeding during this quiet alert stage, which does not go beyond 1 hour. Quiet alert stage, which is a very brief time, maybe half an hour, maybe 1 hour, not beyond 2 hours. This is the place, this is the time when every single baby, eligible baby, should go to mother for her initiation of breastfeeding. So then here, The next limb is the vagal nuclei, the parasympathetic nervous system, which are stimulated. They stabilize the gastrointestinal function of the small babies. They stabilize the growth, and they cardiorespiratory stability also happens, which leads to anti-stress effect. And then it also has this anti-inflammatory, anti-inflammatory. These both are same. The analgesic effect, anti-inflammatory effects are same. And then there is a better immunity of the baby and better survival. So it looks like a complex, but why to remember all this? Initiate, do not miss the quiet alert state. Let every baby, every eligible baby be started on kangaroo mother care. Let every baby initiate breastfeeding as early as possible. That takes care of all these complex neuroendocrine mechanisms. Then the role of oxytocin in temperature regulation is that circulation in the skin overlying the breast is increased during suckling, which results in the increase in skin temperature. This makes suckling more pleasant for the babies. Circulating oxytocin mediates cutaneous vasodilatation. Temperature of breasts and chest increases not only during breastfeeding, but also when milk ejection is triggered psychologically. And the components of kangaroo mother care: position, kangaroo nutrition, and kangaroo discharge and follow in a supportive environment. Supportive environment, all of you know, I would explain a bit. The kangaroo position is skin to skin contact between mother and the baby in a as vertical position as possible, where eye to eye contact between baby and mother are possible. That is the position. And that frog leg position, all that in the workshop, that we will go further. All details of kangaroo position further in the skill stations. Kangaroo nutrition is exclusive breast milk feeding as much as possible. And planned early discharge, because all of us know that kangaroo mother care, which is done in an institute, in a facility appropriately, we can discharge almost all babies early. So, and planning an early discharge and a regular scheduled follow-up, including neuron development that we do, and KMC facilitates all these efforts. The supportive environment is very broad, that contains the family, the society, and this thing. We in the healthcare facility and as community health workers, the clinicians, say the UNICEF, and there are three: the kangaroo nutrition, the kangaroo discharge, and kangaroo position. So these are the prerequisites of kangaroo mother care. For regular follow-up is, we know there are various mechanisms for the regular follow-up. The healthcare workers go, or we have a phone number of all these mothers, and they talk to us regularly, or we talk to them. The kangaroo position, more details in the workshop. And while during kangaroo position, the feeding, and then the discharge, a young couple, they are going home with kangaroo mother care continuing. Then they have returned for the follow-up to the healthcare worker. At home, you see this looks a very modest home where mother is so thin, but it's going on, and the family support. These are all the components of KMC. And what is the duration? Please, this is important. Some people who are really very, very passionate about kangaroo mother care, they would say it is 24/7. 24/7 in enthusiasm, it is good. But what is minimum, I would explain. 24/7, it's not a news channel. Mother has to also sleep. During sleep also, she can give kangaroo mother care. So duration, please concentrate a bit. In one sitting, baby should be held in kangaroo position continuously for not less than 60 minutes. A 50-minute sitting is not KMC. What we would say 90 minutes, that is 1.5 hours. This 90 minutes should be for an effective 60 minutes. Less than 60-minute session of KMC, less than 60, I repeat, less than 60 minutes of KMC is not a KMC duration. We are saying this 90 minutes. Please, at your facility, don't say again, somebody 120 minutes, somebody to another mother, somebody says 180, somebody says 24 inches. Don't say that. Have an institutional protocol for you, all your colleagues. Say this 90 minutes. This 90 minutes would translate to at least the 60. Less than 60 minutes session of KMC is not a KMC session. Shorter duration and frequent handling are stressful to the baby. And also this can, there is a chance of infection also. Shorter duration is not at all recommended. Less than 60 minutes duration is not recommended at all, because this can lead to many other things. This can be stressful to the baby. This can be stressful to the mother. This can be stressful. This can have other potential problems of infections. Sleep, quiet alert state, I have explained a bit in detail. Sleep and sleep cycles are essential for the sensory development of the young baby, creation of long-term memory and learning, preservation of brain plasticity. The neuroplasticity is again a very big word. I will explain a bit. That is what people say. Blood cells would come very fast, skin cells would come say very fast, liver cells regenerate very fast, and the neuron once damaged, neuron once small, it is not. People used to say that, but now people know that even neuron has a chance, and collectively we call it brain plasticity. That is, the baby can adapt. Brain plasticity is a very, very complex word to say. The result of this can lead to long-term memory and learning of the baby even till the adolescence. So if KMC done well for a young baby, for a low-term baby, you are giving a quality of life, for rest of the life. So sleep deprivation in a fetus and a newborn have profound bad effects on early sensory development and creation of permanent neural circuits for the primary sensory system. This is the reason why during antenatal checkup, the healthcare workers, they talk about stressless. Without the pregnant mother should be without any stress. She should have adequate sleep, adequate rest. For these reasons, it is not imposing too many things on this young woman by the mother-in-law. All of us know that a pregnant mother should have all this rest cycle on for the reason that sleep and sleep cycle will have a very facilitatory effects on the central nervous system. And types of KMC are continuous, intermittent. What is continuous? Definitely the continuous kangaroo mother care is ideal, but why intermittent? There are a certain group, a special group of babies where continuous KMC is not possible. When continuous KMC is possible, we will do continuous KMC. It is not the convenience of the mother that we decide which baby should get continuous and which baby should get intermittent kangaroo mother care. It is the baby's condition which decides whether it is continuous or KMC. The continuous KMC is ideal. It is given for all stable babies in the KMC ward or on the low dependency ward. Otherwise, in an NICU, it is given almost 24 hours per day, except during the obligatory breaks like mother's personal needs, her bath, her food and the toilet, etc. For baby, change of the baby's napping, and baby goes for clinical examination or for her cup feeding. Except these essential timings, baby would get otherwise at 24/7 duration of kangaroo mother care. Longer the duration, better the impact of kangaroo mother care. We call it the temporal relation. People who do a lot of big research and they publish in papers, you call it temporal relation. Longer the duration of kangaroo mother care, better and more the impact of its benefits on the baby, and lesser the duration of kangaroo mother care, less is the benefit. That is called temporal relationship. And you are seeing this is an this area where there is oxygen, IV fluids and all, and here is a low dependency where kangaroo mother care is going on. Intermittent KMC. This is not done on 24 hours babies. It is done few hours at a time with a lot of breaks. This is done for very low birth or low birth weight babies, stabilized sick baby within SNCU and NICU, next to the baby's farmer or the baby's cot. So it is the baby's indication especially. The intermittent KMC is actually for a baby who is not really fit for a continuous kangaroo mother care. An intermittent KMC happens for a baby in an SNCU, in NICU, next to baby's warmer, mother goes there. One more indication is mother is recovering from her cesarean section, her tubectomy is done, and not willing. I thought this is our quality. All mothers who are not willing for long hours, we will make them, somehow we will convince them for a continuous KMC. Even short periods of KMC have benefits, but definitely they are short benefits. So go for a continuous, unless not indicated, go for the long duration of kangaroo mother care. This is the intermittent KMC where a very small baby who is getting probably the CPAP or she is getting IV fluids. This baby also getting IV fluids. Still you are doing a kangaroo mother care for her. A stable baby will definitely get continuous care. The intermittent is short, extended and long. The short is up to 4 hours in 24 hours. Naturally, this baby is either in CPAP or who requires 24 hours IV fluids. An extended one is a baby who is still further stabilized, but you cannot shift to mother. Such baby is 5 to 8 hours in 24 hours, and long is 9 to 12 hours, and continuous is more than 24 hours. I'll repeat. The intermittent kangaroo mother care is short, extended and long. Short is up to 4 hours. So we know that the minimum period of KMC duration is 1 hour and the shortest period in 24 hours is 4 hours. Continuous is more than 12 hours in 24 hours. Less than 1 hour duration is not recommended. For intermittent, the shortest duration is up to 4 hours in 24 hours. Continuation is more than 12 hours in 24 hours. It can be even 22 hours. It cannot be 24 hours, of course. Let us be a little practical here. Recorded in last 2 consecutive days of KMC sessions. So if we are monitoring this at the facility, we can explain that how to continue at. Most of the babies would get their kangaroo mother care at their homes in community. So when the babies are with our facility, by the time of discharge, we have to record this last 2 consecutive days, whatever is that, more than 12 hours in continuous kangaroo mother care, nearer to 24 hours. For all stabilized low birth weight babies, including preterm and IUGR, sick infants with low birth weight who are having IV, we know each baby, what is the duration of this? Actually, I cannot have, maybe when we break up in the sessions, we can have interaction also. Here, I cannot interact with you. You know now how many hours this baby would require if you are giving, if you have contemplated KMC, this would be naturally, this indication is intermittent KMC, continuous is not possible for this baby, and the IV fluids, oxygen and CPAP. Let's not talk this. These babies, you would still want to give for 4 hours and intermittent KMC. This throughout the transport, the baby would be, in case possible, mother would be there. And various KMC for the sick baby who is on CPAP during transport, after discharge, KMC at home, and here the healthcare worker is giving advice to the family mother and other family member at home. It is cost saving and quality. I think this we had already discussed. Benefits to the community, I have discussed so far that at the family level, for the community involvement and knowledge in newborn care, the harmful culture and traditional beliefs, because most of the time the baby is with either healthcare worker or with mother, and these people, the harmful effects are gone. Let us not discuss those. This promotes breastfeeding, hygienic practices, follow up the newborn for better assessment of growth and development, so-called neurological development or the developmental assessment. And in case there are any deficits, the early detection is possible in this contingency plan, and early enrollment of these babies for early intervention. So every single aspect of developmentally supportive care are covered if we are doing kangaroo mother care appropriately as per the guidelines. And what are the benefits to the hospital? The technological and human resources are stabilized. We need not buy too many ventilators. If we are cut down by not buying two ventilators, you know how much benefit that is going to be the hospital also. There is less burden on the nurses because the mothers are involved in the care, and they are very most of the mothers, they can give the feedback to the nurses, so there is less burden to the staff nurses. Early discharge saves money, all of us know that. And kangaroo mother care, there is no doubt, we are beyond doubts, it is proved. KMC done well in facility would facilitate early discharge that saves crores and crores of money. And nosocomial infections are not there. The hospital acquired infections are not there. And most medical problems in neonatal period and beyond, we can prevent or minimize. There is less expenditure on artificial milk and less use of equipment and other disposals and other medications. These are all the benefits to the hospital. So this is a very, very cost effective. Benefits to the country is kangaroo mother care is very safe. There is no way you can harm a baby by giving kangaroo mother care. This can be applied to the hospital in the remotest PHC and subcenter. Wherever delivery is possible, KMC is possible. Or every home, KMC is possible. And better utilization of the scant resources would happen. This reduces the burden on health resources, and healthier and intelligent newborns will happen. More kangaroo mother care, more intelligent community. And the key messages are, KMC is not STSC. It is not just keeping a low birth weight baby to mother's chest for whatever time. Anyhow, mothers will breastfeed their babies. It is also breast milk feeding, planned early discharge, regular scheduled follow-up in a supportive environment at hospital, and more importantly at home also. The prolonged continuous duration of KMC offers many benefits which we discussed. Intermittent KMC is also good, but this is for a specially defined newborn babies and mothers. And at every single kangaroo mother place, including my unit and your unit, there is scope of improvement in practice, because we always get new babies and new fresh mothers. So our job is continuous. There is scope of improvement every single facility over time. So KMC is the solution for many preterm morbidities. There are benefits to the baby, mother, family, community, hospital, and nation, and world also. And then it's a very humane approach. Less deaths occur due to if KMC is followed, and there is a better neurodevelopment. I think I'll stop here.
Thank you, Dr. Vijay Kumar sir. That was very insightful. So that told you about why KMC, the benefits to the baby, to the mother, to the hospital, to the society, to the nation. And the key components of KMC. It's not just the mother putting the baby on their chest. There's a process involved.
Dr. Sri Krishna, one word.
Yes,
Before we go further, let me thank Sanjeev sir, you, Som Shekhar sir, Himabindu madam, and all participants right now in the workshop. Thank you.
Thank you, sir. Thanks on behalf of all of them, back to you all as well. So a lot goes into KMC, and this is the science behind KMC. You've seen how beautifully the entire oxytocin and that complex mechanism in which kangaroo mother care saves life. This is like oxygen, this is like antibiotic, this is like any other drug. Kangaroo mother care is a proven evidence-based intervention. It's not just very simple, it's a easy to do, but it is a medicine which saves life. And now let us learn the art of doing KMC. And for this, may I now invite Dr. Himabindu Singh, who's a professor neonatology and one of the strong advocates of breastfeeding and kangaroo mother care in the state of Telangana, and also I would vouch across the country as well. And Madam has been part of many such initiatives. She's a master trainer for all the important workshops and TOTs across the country. Very passionate on child health. I now request Dr. Himabindu Madam to please take over.
Thank you, Dr. Sri Krishna. Very good afternoon to all. My respects to Dr. Sashivani and of course Professor Somashekar. Thank you for this workshop. Associating with. I think that I should really. It's a pride that UNICEF is associated with KMC Foundation as always. Very good regard. My respects to Dr. Sanjeev Upadhyay. Dr. Rekha Udani is also here, senior member, and welcome to all the participants. Dr. Sri Krishna, I just wanted to know the background of the participants. I think most of them are nurses, right?
Nurses and pediatricians, ma'am.
Pediatricians from all over the country.
All over the country. We have some from Kolkata, from West Bengal,
okay.
5 of them from Gujarat. So it's across the country.
Okay, right. So I'll be sharing my slides. So I'll be speaking on the art and science. As said by Dr. Sri Krishna, KMC is very close to my heart. Of course, breastfeeding and all aspects of basic newborn care, because this is really life-saving, and this is having it's very low cost effective, but huge returns and very simple to implement. Now look at we have heard from Dr. Vijay Kumar, Professor Vijay Kumar, about the various benefits of KMC, but let us see it is doable or not. What do you say? It's very difficult to have an interactive session virtually, but nurses आप सब लोग अपने अपने wards में ये KMC I'm sure आप लोग practice कर रहे हैं या practice नहीं कर रहे हैं. आप लोगों का क्या मतलब है कि is it practical कर सकते हैं कि नहीं? Procedure देखेंगे कि बहुत simple procedure है, ये बहुत practical भी है और ये कर सकते हैं. It is doable. इसके बेनिफिट्स काफी अच्छे बेनिफिट्स हैं. फॉर द मदर बेबी इतने सारे बेनिफिट्स ऑलरेडी डॉक्टर विजय कुमार हैज टोल्ड अस कि हाउ मेनी बेनिफिट्स फॉर द मदर, फॉर द बेबी न्यूरो बेनिफिट्स, ब्रेन डेवलपमेंट के लिए बहुत बेनिफिट्स हैं. सो लेट अस सी कैसे करना है इसको. सो इसमें आई विल बी लर्निंग अबाउट व्हेन टू स्टार्ट केएमसी, पोजीशन क्या है, हाउ टू डू इट, एंड कौन कौन दे सकता है KMC, प्री रिक्विजिट्स क्या है बिफोर पुटिंग द बेबी इन द पोजीशन, प्रैक्टिकल स्टेप्स भी सीखेंगे, स्किल्स फॉर कीपिंग द बेबी इन द कंगारू पोजीशन, और ड्यूरेशन ऑफ KMC के बारे में भी डिस्कस करेंगे, एंड व्हेन टू स्टॉप और KMC. सो व्हेन टू स्टार्ट कंगारू मदर केयर, ये इमीडिएटली एज यू नो, जैसे एज सून एज पॉसिबल आफ्टर बर्थ. लेकिन सपोज स्पेशली लो बर्थ वेट बेबी है, प्रीटर्म बेबी है, लेस देन 2 kg, जनरली उस बेबीज को हम स्टार्ट करते हैं जब वो स्टेबल रहती है. बेबी लो बर्थ वेट बेबी कभी कभी अगर प्रॉब्लम है तो उनको थोड़ा वेट करते हैं स्टेबलाइज होने तक. देन वंस दे आर स्टेबलाइज्ड यू कैन स्टार्ट KMC एज सून एज पॉसिबल आफ्टर बर्थ, स्पेशली फॉर अ लो बर्थ वेट एंड अ प्रीटर्म बेबी. So exact timing of initiation of KMC depends on the condition of the baby, condition of the mother, and availability of any other alternative KMC providers, including the husband. So these ये 3 देखना है कि KMC start करने के पहले baby का condition कैसा है, stable है कि नहीं, condition of the mother is receptive है, mother is ready to start KMC, mentally prepared है, और any other KMC provider, because कभी-कभी मदर को ब्रेक चाहिए, she wants to go to the toilet या कुछ उसको ब्रेक चाहिए, तो हस्बैंड या any other family member एक alternate KMC provider बन सकता है. So can be initiated even in mildly sick babies. मतलब just stable babies के लिए पहले हम बोले हैं, but in case even mildly sick baby, मतलब स्टेबल है, कार्डियोरेस्पिरेटरी स्टेटस स्टेबल है, बट चाइल्ड आईवी एंटीबायोटिक्स और मिनिमल ऑक्सीजन, मतलब ऑक्सीजन जैसे हम फ्री फॉर ऑक्सीजन देते हैं बहुत बार. गवाच फीडिंग पे भी ऐसे बेबीज हैं जो लो बर्थ वेट प्रीटर्म बेबीज को थोड़ा टाइम लगता है ना ओरल फीडिंग डायरेक्ट स्टार्ट करने में. सो गवाच फीडिंग जैसे ट्यूब रह के फीड देते हैं, तो उस बेबीज में भी हम केएमसी स्टार्ट कर सकते हैं. सो गवाच फीडिंग के साथ या मिनिमम ऑक्सीजन सपोर्ट पे है और आईवी एंटीबायोटिक्स में भी है, तो ऐसे बेबीज को भी हम केएमसी स्टार्ट कर सकते हैं, बट स्टेबल होना चाहिए. और वेरी लो बर्थ वेट, एक्सट्रीमली लो बर्थ वेट जो लेस देन 1500 ग्राम बेबीज हैं, उनको भी हम दे सकते हैं, बट अंडर एक्सपर्ट सुपरविजन. जीरो सेपरेशन ऑफ द मदर एंड बेबी होना चाहिए फॉर मैक्सिमम पॉसिबल लिमिट, वो हमारा एम है. नाउ बर्थ वेट हम ये 3 कैटेगरीज देखेंगे. बर्थ वेट मोर देन 1800 ग्राम एंड लेस देन 2.5, मतलब 1.8 से 2.5 केजी, ऐसे बेबीज में हम जनरली ये स्टेबल होते हैं एट बर्थ, और केएमसी कैन बी स्टार्टेड इमीडिएटली आफ्टर बर्थ ऐसे बेबीज में. और प्रायोरिटी should be given to less than 2 kg babies. So birth weight, if it is between 1.2 to 1.8, they may have some problems like respiratory distress. तो उनको लेटर्स उनको इंश्योर कीजिए हीमोडायनेमिक स्टेबिलिटी, मतलब उनके हार्ट, रेस्पिरेटरी एंड सर्कुलेटरी सिस्टम स्टेबल होने के बाद में हम स्टार्ट कर सकते हैं. वी कैन इनिशिएट केएमसी इफ इट इज 1.2 और 1.8 बेबीज में. इफ द बर्थ वेट 1.2 के बिलो है, तो ये फ्रीक्वेंटली ऐसे बेबी सीरियसली वो थोड़ा प्रीमेच्योर ज्यादा होते हैं ना, तो उनको रिलेटेड मॉर्बिडिटी जैसे एपनिया या अदर कंडीशन, रेस्पिरेटरी डिस्ट्रेस, ऐसे प्रॉब्लम्स होने का ज्यादा चांस है. सो इन बेबीज में थोड़ा सा ज्यादा, थोड़ा मतलब इट में टेक फ्यू डेज टू वीक्स बिफोर वी स्टार्ट देम ऑन केएमसी. थोड़ा स्टेबल करके ऐसे बेबीज को हम केएमसी स्टार्ट कर सकते हैं. So who can provide? So mother is the best person to provide KMC. All mothers can provide KMC, or KMC particularly beneficial for adults and mothers and for those with social risk factors. ये मतलब mentally मतलब इसमें बहुत सारे benefits हैं. So ऐसे mothers को भी और भी ज़्यादा beneficial होता है. और any other family member also can provide, father, grandmother, or any responsible adult in the family as a family member can give a can KMC. उनको alternate KMC provider बोलते हैं. So mother is the best person to provide KMC. Alternately, of course, fathers को भी involve कीजिए, ये भी बहुत अच्छा से. Actually they love, actually father को हम बहुत बार ये मतलब इतने सालों से हम कभी उनको इतना involve नहीं किया, including the birthing environment या antenatal wards में या labor rooms में, even after birth. तो ये थोड़ा सा हम अभी फील कर रहे हैं कि फैमिली मेंबर्स और स्पेशली फादर को इन्वॉल्व करने में बहुत बहुत बेनिफिट्स हैं. तो इनको प्लीज इन्वॉल्व कीजिए, हस्बैंड्स को इन्वॉल्व कीजिए, फादर्स को इन्वॉल्व कीजिए. इनफैक्ट वो एंजॉय भी करते हैं, उनके पर्सनली उनके एक्सपीरियंस आप पूछिए, दे से दे जस्ट दे लव टू टेक दैट बेबी, उनके साथ में नजदीक रखना, और उनको बहुत अच्छा लगता है. सो प्लीज इन्वॉल्व देम. ग्रैंड पेरेंट्स भी कर सकते हैं. सो फैमिली को इन्वॉल्व करना बहुत अच्छा आइडिया है. सो ये पहले बेसिकली केएमसी प्रोवाइड करने के पहले, जैसे whoever is providing, mother, father, any family member, उनको पहले we should check whether they have willingness. पहले उनको कंसेंट लेना चाहिए, और whether उनको पूछिए उनको कितना टाइम दे सकते हैं, फुल टाइम, पार्ट टाइम, कितना मतलब how much they have time available for them to do KMC. और उनको definitely they should be sure उनके neat and clean होना चाहिए. They should take care of their personal hygiene. So they should मतलब स्नान करके, क्लीन क्लोथिंग, नेल्स भी ट्रिम रखना है, तो ये सब उनको ध्यान देना पड़ेगा. फ्रीडम फ्रॉम सीरियस फिजिकल एंड मेंटल इलनेसेस, तो ये लोगों को ज्यादा मतलब खास इंपॉर्टेंट बीमारी नहीं होना चाहिए. और उनके जो स्किन जो रहता है ना, जहाँ पे हम लोग केएमसी स्टार्ट करें छाती पे, तो लोकल स्किन इन्फेक्शन नहीं होना चाहिए. और सपोर्ट टू फैमिली एनवायरनमेंट, सपोर्ट टू कम्युनिटी, ये ज्यादा इम्पोर्टेंट है. और अल्कोहल एडिक्शन या एनी अदर एडिक्शंस नहीं होना चाहिए. And they should have adequate skills to provide KMC and availability of adequate guidance and supervision. So these are the parameters. इनको check कीजिए ये सब है कि नहीं. जो KMC provider आप चुनेंगे, तो they should have all these parameters fulfilled. So once we select the KMC provider, now you have to also see where you can do the KMC. कहाँ हम कर सकते हैं. KMC कैन बी प्रोवाइडेड एनीवेयर, एक्चुअली हम बोलेंगे कि बेड साइड में भी दे सकते हैं, मतलब अंदर SNCU के अंदर, NICU के अंदर, बेड के बाजू में जो बेबी वहाँ पे वार्मर के अंदर है, तो वो बेबी जब उसका मतलब थोड़ी देर के लिए मदर वहाँ भी अपना KMC चेयर लेके कॉर्नर, मतलब वहाँ पे एकदम बच्चे के बाजू में NICU के अंदर ही KMC हो सकता है। और सेपरेट KMC वार्ड, डेडिकेटेड वार्ड्स आजकल एस्टैब्लिश हुए हैं। हमारे यहाँ नीलोफर में भी, आई शो यू इन द डेमोन्स्ट्रेशन लेटर, कि एक कंप्लीट एक वार्ड डेडिकेटेड फॉर KMC है एस्टैब्लिश। वहाँ पे काफी मदर सब साथ में मिलके, वो भी बहुत अच्छा है ना, दे कीप टॉकिंग, सब लोग मिलजुल के करते हैं, उसमें भी काफी बेनिफिट्स है, ग्रुप काउंसलिंग भी हो जाता है। ये KMC कॉर्नर और एक प्राइवेसी होना चाहिए एटलीस्ट। तो ये सब इंश्योर कीजिए, और एनवायरमेंटल टेम्परेचर शुड बी वार्म इनफ फॉर द स्मॉल बेबी एंड कंफर्टेबल फॉर द प्रोवाइडर। सो रूम थोड़ा वार्म होना चाहिए, इट शुड बी एटलीस्ट 25 डिग्रीज, वेल लाइटेड वेंटिलेटेड प्लेस होना चाहिए, कंफर्टेबल प्लेस फॉर द मदर, और होमली एटमॉस्फेयर रखना चाहिए अंदर ना। जब वो KMC वार्ड में भी, इसलिए आप हमारे यहाँ देखेंगे टीवी रखा हुआ है, तो वो लोग मतलब एंजॉय भी करते हैं सब लोग, चेयरफुल एनवायरनमेंट एकदम, एटमॉस्फेयर थोड़ा सा अच्छा से, इट शुड बी लाइक अ वेरी ब्राइट एटमॉस्फेयर, प्रेफरेबल टू हैव अ क्लीन वार्म एरिया ऑन मदर्स बेड फॉर द बेबी। तो बाद में जब बेबी को अगर कभी कभी हटाते हैं, तो बेड ऑल्सो शुड बी वार्म। So these are the various places you can do the KMC, inside the NICU or in the KMC corner or a dedicated KMC ward. घर पे भी कर सकते, देखो तो लास्ट फोटोग्राफ, ये कम्युनिटी घर जाने के बाद में, डिस्चार्ज होने के बाद KMC घर पे भी कर सकते हैं। सो बस इम्पोर्टेंट है कि एकदम पहले उसको, आफ्टर यू आइडेंटिफाई द KMC प्रोवाइडर, प्लेस भी देख लिया, तो इफेक्टिव काउंसलिंग कीजिए बिफोर यू स्टार्ट द पोजिशनिंग एंड अदर थिंग्स। सो दिस इज वेरी इंपॉर्टेंट प्री रिक्विजिट टू ओवरकम एनी बैरियर्स और एंजाइटी। तो मदर्स को काफी एंशियस होते हैं काफी बार, कि बिकॉज ऑफ प्रीटर्म बच्चा, लो बर्थ वेट बेबी, एक मतलब वेट कम होता है ना, तो वो लोग उठाने में भी उनको थोड़ा सा डर लगता है, काफी एंशियस होते हैं कि ये नॉर्मल है कि नहीं, हम कर सकते हैं कि नहीं। सो इनको वंस यू काउंसल देम, दे आर वेरी कंफर्टेबल। सो उनको प्लीज इन रिक्वायर कंप्लीट कोऑपरेशन फ्रॉम द KMC प्रोवाइडर। So it's very important you give time for counseling, prepare them properly for successful KMC. So multiple sessions के भी जरूरत पड़ेगा, इसलिए उनको अच्छा से काउंसलिंग कीजिए एंड उनको कॉन्फिडेंस बढ़ाइए टू हैंडल स्मॉल बेबीज। एंड अगर फैमिली के साथ में काउंसलिंग करेंगे तो और भी अच्छा है, हस्बैंड और अदर फैमिली मेंबर्स के साथ में, so that they can take turns and they can be totally supportive environment बन जाएगा। तो वन टू वन काउंसलिंग इज डिफिकल्ट कभी कभी ना, तो बहुत सारा टर्नओवर होता है, वी आर वेरी मच ओवरलोडेड, तो ग्रुप सेशंस भी ले सकते हैं। तो दिस इज एक्सट्रीमली, एक्चुअली इसका भी बहुत अच्छा सक्सेस होता है ग्रुप सेशंस में। एक मदर दूसरी मदर को भी बताती है कि हम कर रहे हैं, so इट विल बी लाइक अ वेरी नाइस पीयर एजुकेशन हो जाता है। So these are the various things you require. You can have a cot में भी कर सकते हैं, फॉलोअर बेड पे जैसा थोड़ा सा एडजस्ट कर लें बैक रेस्ट को, और रिक्लाइनिंग चेयर्स, वी हैव KMC चेयर्स आजकल अवेलेबल हैं। एक फुट रेस्ट होना चाहिए ताकि मदर को थोड़ा आराम मिले, क्लीन शीट्स, ब्लैंकेट्स, एक्स्ट्रा पिलोज, और मदर को एनी सूटेबल ड्रेस, ऐसे पर्टिकुलरली से वी हैव लॉट ऑफ थिंग्स, जैसे हमारी KMC स्लिंग्स है, काफी कंपनीज आर कमिंग विद काफी काफी मॉडल्स आ रहे हैं, बाद में हम डेमोन्स्ट्रेट करेंगे। बट यू कैन वी कैन से दैट फॉर इंडियन सेटअप, एनीथिंग लूज ड्रेस, मदर की नाइटी है फ्रंट ओपन, और फिर या शर्ट, हस्बैंड के शर्ट यूज करते हैं, ब्लाउज एंड साड़ी में भी हो जाएगा। सो बट द स्किन टू स्किन कॉन्टैक्ट इंश्योर करना है। So we have to, any dress can be utilized, it can be suitable dress होना चाहिए which is front open at least. So and then baby के लिए क्या क्या होना चाहिए, कैप होना चाहिए, और बेबी को when उनको जब रेडी करते हैं तो सिर पे थोड़ा कैप होना चाहिए, सॉक्स, मतलब जैसे लेग्स पे सॉक्स होना चाहिए, और नैपकिन, डायपर्स थोड़ा पिना दो तो थोड़ा गीलापन नहीं होगा, तो कंफर्टेबल रहेगा। एंड फ्रंट ओपन टॉप्स, बच्चा को अगर कपड़ा पहना रहे हैं तो जबला जैसे फ्रंट ओपन होना चाहिए, पीछे से कवर्ड बट फ्रंट में ओपन होना चाहिए। और KMC स्लिंग्स यूज कर सकते हैं, जैसे हम बता रहे हैं इसको, KMC स्लिंग्स एंड बैग्स, दिस आर अवेलेबल, जहाँ पे बच्चा दे कैन सिट, उनको प्लेस करते हैं दो, ऐसे वी कैन यूज दिस। तो डेमोन्स्ट्रेशन में बताएंगे आपको रियल टाइम कैसे करते हैं, हम डेमोन्स्ट्रेट करेंगे आपको बाद में। और शीट्स, एक KMC रिकॉर्डिंग शीट, ये सब इम्पोर्टेंट है बिकॉज रिकॉर्डिंग इज वेरी वेरी इंपॉर्टेंट, ड्यूरेशन ऑफ KMC कितना हो रहा है, और एक्चुअली हम लोग यहाँ पे मदर्स को भी इन्वॉल्व करते हैं, वो खुद अपना स्टार्टिंग टाइम एंडिंग टाइम लिखते हैं, और उनका वेट गेन भी चेक वो खुद करते हैं, बिकॉज वो खुद अपने आंखों से जो वेट गेन देखते हैं ना, दे फील वेरी वेरी, उनको अच्छा लगता है, एंड दे फील कॉन्फिडेंस बढ़ता है, एंड दे फील मोर मोटिवेटेड. So you have to prepare the mother or the kangaroo provider with you have to see that the nails are cut, उनको rings, bangles, jewelry ये सब चीज हटाना है, और अच्छा से बात लेके ना wear clean washed clothes, और hair अपना tied up खुला नहीं छोड़ना है, and comfortable loose fitting clothes पहन के which is front open, और बेबी को भी अपना वैसे टाइप का ड्रेस which is front open उसको लेके. Then proper hand wash, very very important before you start doing this. अपना hands, clean hand hygiene is extremely important. ये सब procedures में in neonatology newborn को जब handle करते हैं, this is the first very very important thing. Please ensure a good proper hand wash so that we don't spread infections. So when you for the baby, front open as I already said, कि front open thin soft cotton जबला और small shirt use कर सकते हैं, head covered होना चाहिए, and feet legs को socks पिना दो, फिर अपना napkin भी napkin पिनाओ बच्चा को, and then you can use slings, KMC binder wraps may be used to secure the infant. Once the binder could be long towel, you know, the binder अपने just proper slings, or you can use dupatta, और you know KMC wraps, काफी चीज मिल रहे हैं आजकल मार्केट में. But anything like I said कि बस you have a loose dress for the even the साड़ी ब्लाउज में भी हो जाएगा, but एक कपड़ा मिलता है हर घर में, clean cloth like a binder so that you support the baby, ये सब चीज अपना यूज कर सकते हैं. फिर एक एक्स्ट्रा शीट भी रख लेना to keep the baby, एक्स्ट्रा कवर after you fix करने के बाद बेबी को बाकी ऊपर से you cover the baby and mother together with an extra blanket or bed sheet. So this is how you showing, this is a slide showing how to prepare the baby for KMC. देखा है ना? So socks पहना के, napkin, there's a head टोपी लगाते हैं, cover cap. But front open, छाती open होता है बच्चे का, पीछे से covered. ये sling में, the second वाला जो है, this is actually the sling use किया इधर. So first hand wash, उसको mother को ready करेंगे for KMC. So she is counseled, she is confident to start, और बच्चा को कपड़ा ऐसा पहनाते हैं. So this ये देखिए बच्चा is all गवाच feeding, और even on intracath है, उसको antibiotics या कुछ चल रहा होगा, but baby is stable इसलिए इसको ले लिया. So this we can do KMC for this baby. And then ये bag में ऐसे रखते हैं ना, ये legs निकल जाएंगे, मतलब ये sling में you can see that there's a hole where the child can put his legs out. जैसे ये, these are the two things. So the mother's chest is ready for direct contact now. She has taken bath and there's no local infection. Hand wash भी कर लिया, and the baby को अभी ऐसे रखते हैं on the mother's chest. So front देखिए, in between the baby and the mother chest कुछ भी नहीं है. It's all skin to skin contact. But skin to skin contact और KMC में थोड़ा difference है. KMC is more scientific. It is ये particular position होता है, and you know we have to. This is called KMC, not just skin to skin contact. The head ऊपर है, थोड़ा slightly extended, so that the nose is free, and this is a frog position. ये two hands ऊपर ऐसे folded होते हैं, और legs को भी नजदीक frog के जैसे ले लेते हैं. So this is the position you fix the baby onto the chest of the mother. ये bag, when you use a bag, how to fix the bag? इस picture में demonstrate हुआ है, and this is the position. Fix होने के बाद में you can actually just slightly extended neck, and you will support the neck, and the bottom is very very important. And फिर extra ऊपर से mother will lose उनका जो nighty है या front open dress है, उससे cover कर लेगी mother को, baby को. And additional sheet can also be used, so they're covering the baby, mother and the baby together. So this is how, and the mother is comfortable with a little footrest for the mother to relax. This is the KMC chair used here. And actually, mother's hand should be free so that she can do her rest of the work. You know, when the baby is confidently, properly tied with a good support, her two hands are free. She can walk and do other activities. So even in the house when she goes home. Actually, this is a picture where how these two mothers are relaxing with the baby in KMC position. So, so actual steps. Actually, we describe, then we demonstrate with a doll and mannequin. I'll show that in the next practical sessions. And then the mother actually goes through. So you can do that in your own wards. Show the mother already holding a KMC in position. And this is actually builds the confidence. You can show pictures or you can show actual mothers who are doing KMC. This is with the mannequin. Mother can stand or sit on a reclining chair. Alternately, you can adjust the backrest of the cot, or pillows can be put on the backrest. On bed pay, you can just put two pillows so that a 45 degrees की position बन जाएगी. Baby can be transferred when the mother is standing or sitting. A well-prepared naked baby clad only with diaper, cap, and socks. Lifted gently with constant support behind the neck. This is important. And baby is placed directly on the mother's chest between her breasts in direct contact with the skin in upright position, head turned slow towards one side and neck in a slightly extended position. So this is how it looks like. So the baby is between the mother's breasts and supporting the baby's bottom is important. Frog-like position and head is turned to one side. So this is the correct KMC position. So different pictures showing the same. And additional support KMC bags, actually this also can be used, or a binder like this. So, and please avoid overflexion or overextension of the neck. Baby's face should be visible all the time. So Mark should be seeing, Mark can see should be able to see the eyes or the face of the baby. The baby's chest must be touching with the mother's bare chest. That's called the body hug. Keep the lower leg flexed in a frog-like position and the arms in a flexed position above the mother's breast. Provider supports the back of the neck to prevent sudden extension or undue flexion. Supporting the back is very, very important. So what is safe position? This is the checklist. So whenever आप लोग ये position करेंगे ना, तो आप checklist रखिए. So checklist actually is very important practically when you do it in day to day. कभी-कभी छोटा-छोटा point miss हो सकता है. So this when you have a checklist, this can help that no mistakes are done. इसमें checklist में face देखिए face can be seen or not. Head is in sniffing position. Sniffing मतलब slightly extension. Nose and mouth are not covered. ये cover नहीं होना चाहिए. Head is turned to one side. So yes or no, you can check and tick it. Neck is straight, not bent and well supported from behind. Shoulders are flat against the mom. Chest to chest with mom, preferably between the breasts. Legs are flexed below the breast in flock-like position. Bottom is supported. Mother is little upright, not flat on bed. So mother should not be totally flat. Should be in a reclining position and cover the back with blankets. Bodies, both are washed when sleeping and baby is being monitored. So this is the checklist. Once you position the baby, you should check whether all these things are there or not. If no one can watch you and your baby after feeding and when sleep is likely, put your baby on his or her own back on the baby's own firm bed. So activities mother can do during KMC, she can sit, stand, walk, engage in simple activities, and if comfortable, she can sleep with the baby on the with the kangaroo position in a reclined or semi-recumbent position. So she वो सो सकती है, चल सकती है, खा सकती है, and while दोनों भी मतलब when both of them are sleeping, the mother baby dad must be under constant observation because ये important है कि दोनों under observation हो. And when not in kangaroo position, baby must be in a warm, well-ventilated, clean area, safely covered and well observed. So relax. This is very, very relaxing for the mother, in fact. So different positions, cot में भी हो जाता है. And special situations में, in advanced centers, 6 babies after stabilization with continued oxygen and IV fluids and antibiotics, they're also put on KMC as early as possible. So ये भी करते हैं, but this will be under very strict supervision. Even in twins, it is possible to give KMC either by only mother or with the help from another provider. C-section also we can do, either the mother or another provider can give KMC. Advanced centers, ventilated or CPAP babies को भी किए हैं. So it's not that is for routine things. These are special situations. Sick babies also we can do. Even in twins, even in a cesarean section we can do KMC. Even when the baby is ventilated or under CPAP, with lines and tubes also are put under KMC, but these are special situations, but they require continuous supervision. So that is to be ensured. Continuous monitoring has to be maintained, and this will be under supervision. So with CPAP, these are pictures. So even with CPAP, the baby is receiving KMC, sick baby, twins, and triplets. So each sitting, baby to be kept in KMC position for at least 1 hour. The baby can complete one cycle of good. This is 1 hour में at least एक उसका नींद हो जाता है. REM sleep complete होता है. So therefore we insist that 1 hour at least minimum should be given. Advise the mothers for each sitting of 1.5 hours ensures full 1 hour of deep sleep. So at least 1 hour of deep sleep होना चाहिए. So frequent handling is stressful to the baby and disturbs the sleep. So don't disturb the baby frequently. And each sitting can continue as long as the mother can do it comfortably. Frequent such sessions can be done in 24 hours of a day. So you can actually prolong, at least within 1 hour se shuru kijiye, you can actually do it for 3 hours, 4 hours, more than 12 hours. So as long as possible, this can be done. Very, very beneficial both for the mother and the baby. And for can be interrupted only temporarily for these reasons. Whenever we want to change the diaper, changing the clothes, or clinical assessment, doctor आया है देखना चाहता है, and mother has to go to the toilet, or sometimes for some reasons like backache, stitch pain, this can be interrupted for a short time, or some other provider can continue to give KMC. So when to stop? So continue KMC as long as mother and baby are comfortable in the hospital and at home also. इसको discharge के बाद भी करना चाहिए for low birth weight babies at home. So please ensure when you discharge this low birth weight babies, you give this very, motivate them to continue KMC at home. Continue until the baby reaches term, at least 40 weeks or weight of 2.5 kgs. Wean the baby gradually from KMC when the baby wriggles out and uncomfortable. उसको अच्छा नहीं लग रहा है. Baby wants to come out, pulls legs, limbs out, cries and fusses every time the mother tries to put her back to skin, and mother can continue short, in those babies, you can do at least short skin to skin contact after giving birth to the baby or in the cold nights. But this is how, when you stop the KMC, these are the things. So when it crosses 2.5 kg or 40 weeks, or baby is uncomfortable, wriggles out, cries, fusses every time you put the KMC, then you can stop the KMC. So I leave with these key messages. So kangaroo position is a direct skin to skin contact on mother's chest, better described as a loving hug by mother. ये मतलब प्यार की जप्पी बोलते हैं इसको. So loving hug by mother and a baby, and ममता की जप्पी. Okay, this is what we colloquially say. कि इसको ये बोलने से ये सब तो very naturally maternal instinct है. Even parents and all families do it. So we are, this is our marketing style to say, let us give the mamta ki zappi for these babies. KMC can be given to all low birth weight babies, including preterm babies, and but in hospitals, priority should be given to at least 2 kgs and less. Initiate KMC as soon as possible after birth. Minimize mother-baby separation as much as possible. All the healthcare workers, including nurses and doctors, must be well trained for KMC. Please, I would leave this with a strong message कि राउंड्स में जब आप एसेंशियल नर्सेज हैं सब लोग, तो राउंड्स में डॉक्टर्स, हम तो यहाँ पोस्ट ग्रेजुएट्स या नर्सेज हमारे डॉक्टर्स को इंस्ट्रक्ट करते हैं कि प्लीज राइट इन द केस शीट KMC इज पार्ट ऑफ मैनेजमेंट. तो उसमें लिखिए ऑक्सीजन, IV फ्लूइड्स कैसे लिखते हैं, KMC भी लिखिए, तभी वो रिकॉर्ड होगा, डॉक्यूमेंट होगा, अपने सॉफ्टवेयर में चढ़ेगा. So it is also part of treatment or management of low birth weight, especially for low birth weight babies. So kindly make it a habit to instruct KMC in the case sheets. Thank you so much. It is doable, practical, and it is very, very simple procedure. Thank you so much.
Thank you, Dr. Himabindu. All the passion and your commitment shows in those 20 minutes. Thank you, ma'am. Thank you. And you'll see the unit and the Zoom breakout sessions, a wonderful KMC award at Nilofer Hospital as well. Thank you, Himabindu, ma'am. Now we move on to the next session. So we have seen the science behind KMC. Why is it useful? What is the evidence? What is the benefit? Now we have seen the art of KMC. How do you really do this on field? What is the exact procedure? What are the prerequisites? What is the process? And now let us take it forward. And may I now request Dr. Aparna to tell us about the monitoring of KMC, the key factors which are required for identifying the danger signs. What do you do when you are managing a baby on KMC? And what are the things to be kept in mind for discharge and also follow? now hand it over to Aparna. Aparna, please go ahead.
Can someone enable me to share my slides, please?
Yes, you're a co-host now, Aparna. You can share your slides.
So thank you very much, Dr. Sri Krishna, and thank you UNICEF for giving me an opportunity to be a part of this virtual KMC conference. And I hope you're all able to see my slides. I'm just making it full screen mode. Dr. Sri Krishna, can you confirm you're able to see the slides?
Yeah, please go ahead.
Okay. So over the next 30 minutes, we will be discussing about some aspects of clinical monitoring of newborns during kangaroo positioning. We should also be covering the criteria for discharge and follow-up, which are very vital aspects. And one of the three core principles of KMC also, you know, is early discharge and follow-up. The learning objectives of this presentation will be to understand the importance of monitoring during kangaroo positioning. What are all the vital signs we will monitor? How are they to be monitored? How to recognize danger signs? We shall be identifying the babies who need additional.
2 lakh cases వచ్చినాయనే ఎప్పుడు నేను.
We shall also be learning how to monitor a baby receiving KMC and how to educate the mother in monitoring her KMC baby. So we all know that we are moving towards family-centered care, and it is very, very important not only we as healthcare providers to be aware of monitoring, but it is also important to be aware of how to educate mothers and what all to educate mothers while they are providing kangaroo care. So first of all, why is monitoring so important? Monitoring, we all know, during kangaroo mother care and overall monitoring of a preterm baby in the NICU is important to ensure the well-being of the baby, especially in this case, well-being of the baby during kangaroo mother care. It increases the mother's confidence and compliance. It also helps us to address problems early. Say if the baby has apnea, or if the baby is developing hypothermia, if the baby is developing acrocyanosis, it helps us to identify these problems early and initiate timely interventions. So which are the babies who need monitoring? Of course, all babies in kangaroo positioning, especially in the first few days, require close clinical monitoring. But there are some special situations. There are babies who require additional monitoring, and these include extremely low birth weight newborns, babies born below birth weight of 1000 grams, babies who are on respiratory support. So like Dr. Himabindu said, babies who are receiving CPAP or hyponasal cannula. There are units which have successfully given KMC for babies who are ventilated as well. Multiple gestation, twins, sick babies, babies who are on inotropes, babies who are on parenteral nutrition. KMC during transport, and especially when the mother is not confident while providing KMC. So these are all special situations or special scenarios where monitoring needs to be done very, very closely. Next, we are going to discuss what parameters need to be monitored during KMC. So like in any initial stabilization, we talk about TAPC, temperature, airway, breathing, circulation. So we monitor the baby's temperature. Where do we monitor? Usually we measure the baby's axillary temperature. Now in routine warmer care, the baby will be connected to a skin probe which is placed on the baby's right hypochondrium. Whenever we suspect hypothermia while in kangaroo position, you can check the baby's axillary temperature. A for airway, apneas. Is the baby breathing well? Is the airway clear? B for breathing. So we check the baby's respiratory rate, the work of breathing, retractions, any grunt, etc. Circulation, color, heart rate, capillary refill time, etc. Now essentially all these parameters need not be monitored continuously, but one needs to check the baby's temperature, whether the baby is developing apnea, whether the baby is having any increase in the work of breathing, the baby's color, and the baby's feeding as well as growth. Now, all above clinical observations and the duration of KMC must be recorded in the newborn case sheet. So, as Dr. Himabindu Madam also told us, it is not only important to be aware of the benefits of KMC, but the duration of KMC should be monitored on a daily basis And ideally, it must be part of the vitals chart or the nursing chart which every unit has. So like you record the baby's heart rate, respiratory rate, blood pressure, it is also very, very prudent and appropriate to record the number of hours of KMC that have been provided every day. And this should be one of the parameters that will reflect the quality of care that we give to our preterm babies. So how is monitoring practically done? The temperature, as we discussed, the axillary temperature is recorded 6 hourly in a stable baby. It may be recorded more frequently, like 2 hourly in special situations, like extremely low birth weight baby or a sick baby or a newborn who is on inotropes, etc. And in simple words, the mother as well as the care provider must know how to check the baby's peripheries as well as the baby's coat, that is the abdomen as well as the baby's hands and feet are to be palpated, touched regularly to ensure that the peripheries are as warm as the baby's central part. Now, airway, we all know that the neck position should be maintained at slight extension, which will provide proper alignment of the airway and ensure that the airway is patent. Breathing, the baby's respiratory rate should be counted at regular intervals, and the breathing must be regular, and the baby should not have any increased work of breathing while in kangaroo position. So in the form of retractions, grunting, etc. The baby should be pink. Feeding wise, one must encourage breastfeeding while in KMC position. So many babies will naturally learn to kind of cling on to the mother's breast and may try to latch onto the nipple, and they should be encouraged to breastfeeding while in kangaroo position. Now, when it comes to growth, we all know that the growth parameters, namely weight, length, and head circumference, are monitored in all preterm growing very low birth weight neonates. So there are parameters like length and head circumference, which you may want to monitor on a weekly basis, and weight is recorded more regularly, usually daily, although it can be also done less frequently, maybe once in 2 to 3 days. So close monitoring in the initial KMC sessions until the mother is confident. Then slowly, when the mother gains confidence and when the baby also is more stable, the frequency of monitoring while in KMC can be reduced. Now, how to educate the mother? As we discussed earlier, it may not be possible for us to constantly monitor the baby, especially in busy centers, from the time of initiation of KMC till the time of discharge. So it is very, very appropriate to educate the mothers in monitoring the babies while in kangaroo positioning themselves. So mothers should be taught to observe the baby, to recognize apnea. So they should be told that cessation of breathing more than so many seconds must be intimated. They can be taught to look at the pulse oximeter probe, the pulse oximeter recording waveforms, which would be connected to the baby even in kangaroo positioning. Mothers can be educated to recognize signs of breathing difficulty, feed regurgitation, or frothing from the mouth. Look for cyanosis or bluish discolorization of the hands and feet, decreased activity, any abnormal movements in the form of convulsions, decreased feeding or difficulty in feeding, and signs of hypothermia, that is cold hands and cold feet. They must also be taught to recognize high temperature or hyperthermia, and in the long run, we need to also tell them what is optimal weight gain. So we know that these are some important danger signs. Apnea. What is apnea? Apnea is defined as intermittent cessation of breathing efforts for 20 seconds or more, or even for a shorter duration if it is associated with reduction in heart rate. So the mothers should be taught to initiate gentle physical stimulation in the form of tapping of the soles or rubbing the back before calling for help. Now, in terms of breathing difficulty, again, mothers can be taught to recognize the signs of breathing difficulty in the form of fast breathing, that is breathing more than 60 breaths per minute, or very slow breathing. So shallow breathing, slow breathing, respiratory rate less than 30 breaths per minute may also be abnormal. Similarly, if there is irregular rate or rhythm of breathing, like when there is periodic breathing, there are few seconds of hypoventilation or apnea followed by rapid breathing, or signs of increased work of breathing such as grunting, stridor, and retractions. All these must be identified, and these are simple things which can be easily educated to most mothers. Similarly, regurgitation of feeding or frothing from the mouth, the mother can be trained that whenever the baby regurgitates feed, she must turn the baby to one side and clear the mouth in order to prevent aspiration. If the mother notices the baby to become cyanosed or dusky, then again she can alert the doctor. And convulsions, which are defined as any abnormal movement of the body. So this can be in the form of subtle movements like rolling of the eyeballs, up rolling of the eyeballs, abnormal vacant stare, or lack of blinking. Or there can be oromotor movements like lip smacking, hypertonic posture or tonic posturing of the neck and the body, opistotonic posturing we say, cycling movements of the hands and feet, and abnormal fisting. So all these are abnormal movements which also can be easily recognized by most parents. And there comes temperature. So hypothermia. Now, simplest tool to recognize hypothermia is a palpatory method. So all mothers can be taught to palpate the baby with the dorsum of the hand over both the periphery, that is the hands and feet, as well as over the abdomen. Usually, the baby's abdomen as well as the hands and feet should both feel warm. This is normal temperature. However, if the baby's abdomen is warm but the hands and feet are cold, this signifies cold stress or mild hypothermia. So the mothers must be told to immediately wrap the baby properly, including putting the cap and ensuring that the entire body of the baby is wrapped with a warm cloth, and she can hold the baby in direct skin to skin contact. Now, the other danger signs include decreased activity, decreased feeding, or any difficulty in feeding, like where the baby may try to latch but is not able to suck continuously for more than a few sucks. The baby developing hyperthermia, that is temperature more than 37.5 degrees centigrade or fever, or a baby with inadequate weight gain. Now, all these may be signs of other potential problems, including infections or abnormal levels of electrolytes or intracranial problems, etc., etc. And these must be promptly evaluated, and appropriate management based on the diagnosis must be initiated. So every mother must be first educated about what are the important danger signs, and must also be told about potential immediate actions, like how to stimulate the baby, gently stimulate the baby if the baby develops apnea, how to wrap the baby if the baby develops hypothermia, etc., before she calls for further help. Now let us discuss a little bit about discharge during KMC and the objectives of follow-up. So we shall be discussing all these in the breakout rooms as well. So one needs to be aware, all of you need to be aware of what are the objectives or what are the criteria for planned early discharge in terms of criteria for the baby, for the mother, and for the family. And there must be an organized set of actions for post-discharge continuation of KMC. And what are the skills for detection of danger signs or immediate actions to be taken while at home, and criteria to stop KMC. So we all know that early discharge is the third and very important component of kangaroo mother care, in addition to skin-to-skin contact and exclusive breastfeeding. So a fundamental prerequisite for early detection and for early identification and intervention of problems in growth and neurodevelopment is to have regular follow-up. So why should we follow up our babies? It is because we must detect abnormalities or deviations from normal growth, normal neurodevelopmental potential, and also for detecting other behavioral and neurosensory problems, and also for ensuring adequate immunization. So planned early discharge combined with appropriate or effective post-discharge continuation of KMC and good follow-up is a very, very important prerequisite for delivering a continuum of care for preterm low birth weight babies. And this is more and more being recognized in countries such as India, which have a large burden or large number of preterm babies. So these skills necessary for KMC and for essential newborn care must be learned by mother as well as by the family members. So which includes thermal care, feeding, keeping the baby clean, and protection or prevention from infections, and basic medications. This must be taught to all the mothers and the family members. And this goes a long way in reducing the hospital workload, to reduce crowding and congestion in crowded NICUs and SNCUs, where the bed may be required for a more needy and sick low birth weight baby. So it also reinforces the skills for KMC and essential newborn care in the family, and it reduces the hospital workload. We discussed this. Now, eligibility criteria for early discharge in a KMC baby. So what are the criteria? When it comes to the baby must have satisfactory regulation of the vital parameters, which means the baby must have normal breathing status, the respiratory rate should be normal, work of breathing should be acceptable, the baby must be free of apneas, and baby must not be on any medications which prevent apneas, such as caffeine. So this must be stopped at least 3 to 5 days before the discharge of the baby. And even without these medications, it must be ensured that the baby has regular breathing. The baby must be having adequate coordination of sucking, swallowing, and breathing while breastfeeding. So this is another important prerequisite when it comes to feeding. Now, the baby must also be on predominant breast milk feeding. So as a rule, we try and encourage exclusive or at least predominant breast milk feeding in all preterm low birth weight babies. Every effort must be taken to promote the intake of mother's own milk in every baby who is, especially who is low birth weight. Adequate weight gain must be documented for 3 consecutive days before discharge, and this is defined as at least 15 grams per kg per day. Now, when it comes to the criteria for planned early discharge of the mother, the KMC mother, the mother should be physically and mentally well prepared and confident for taking care of the baby at home. She must be confident of providing kangaroo mother care in particular. So about positioning the baby in kangaroo positioning, monitoring the baby during kangaroo positioning, recognizing various danger signs, and being able to provide early interventions wherever appropriate. The mother must be having adequate breast milk, and this is again, as we discussed, a very important prerequisite. So wherever situations arise where the mothers are not able to provide adequate breast milk, every effort must be taken by the healthcare provider to increase the mother's production of breast milk by various interventions like early and frequent pumping or expression of breast milk, by ensuring adequate hydration and nutrition for mothers, ensuring adequate relaxation, building up their confidence, alleviating pain, and teaching them the importance of good latch, frequent feeding, especially during nights. So these are all measures which improve the secretion of prolactin and other essential hormones, which are important for ensuring adequate lactation, and also to ensure that the family gives adequate support not only during hospital stay but also after discharge at home. And the mother also should not have preferably any skin infection over the chest, and she herself should not be having addictions or sleep problems, or should not be on antidepressant medications, other potential medications which are typically contraindicated during breastfeeding. When it comes to the family must be allowed to provide support to the mother who is providing KMC. The family must have adequate facilities at home in terms of space and in terms of privacy in order to support kangaroo mother care at home. The family, especially the father, must be able to help the mother in all the domestic chores, and the mother's time and energy must be reserved exclusively for the care of the low birth weight baby, in providing kangaroo mother care, in providing breast milk. And of course, the family must be able to provide support to the mother for bringing the baby over for follow-up visits, and must also allow the community health worker to come home for home visits wherever required. So discharge can be delayed if follow-up services are not available, where hospital is far away for the baby to access immediate care in case of emergencies, and when the home environment or family support is felt to be not very conducive for discharge, and whenever the mother is physically or mentally unfit to provide KMC. So there may be some exceptional situations where mother is sick, or the family members are not available, and the home is situated very far away from the nearest health facility, where it may be prudent to delay the discharge till it is felt that it is safe to discharge the baby and the mother. So I'm going through the danger signs one more time. A for apnea, which is defined as the cessation of breathing for more than 20 seconds. B for breathing difficulty. C for chest indrawing, cold hands and feet, convulsions, change in color. D for decreased feeding, decreased activity, and diarrhea or watery loose stools. And H for hypo or hypothermia. So this is captured in the danger signs for KMC, in the checklist for the danger signs. And it is important for the healthcare provider to reinforce the knowledge and the skills required for kangaroo mother care before a planned early discharge. Not only kangaroo mother care, but in also all the other skills which are required for the care of the low birth weight baby, which includes the appropriate method for kangaroo positioning, technique of breastfeeding, technique of manual expression, correct method of hand washing, and the correct technique of assessment of the baby's body temperature by hand palpation. It may also be preferable to teach parents how to use a simple thermometer, a digital thermometer, wherever it can be possible, and how to check the axillary temperature using the digital thermometer. The family must also be educated on putting the baby in a clean, warm bed in supine position during a short interruption of kangaroo mother care, and must be taught how to swaddle the baby. So the preparation for early discharge must include pre-discharge counseling of the mother and her family, reinforcement of all the knowledge and skills that we just discussed, and discussion on when and where to refer and how to transport the baby in direct skin-to-skin contact whenever required, and the importance of follow-up. So also it is important for us to tell the exact date, time, and place where the mother should bring the baby for follow-up and what all we will be observing in various follow-ups. For instance, when will the next retinopathy of prematurity screening be done? When would the baby be required to come for a term neurosonogram, etc., etc. We also educate the family about when immunization would be planned and what is the plan for generally for immunization, the specialty follow-up visits, if at all required, like ophthalmology or a pediatric neurology follow-up, etc., etc. So these are the aspects of the pre-discharge checklist, which include pre-discharge counseling, correct kangaroo position technique, breastfeeding technique, technique of EBM collection, which means expression, storage, and administration of EBM, correct technique of hand washing, teaching the family on the touch technique for assessment of body temperature, safe placement of baby when not in kangaroo mother positioning, detection of danger signs, when and where to refer, and importance of the knowledge of appropriate follow-up schedule. The mother should also be taught how to sponge the baby and must discourage bath until the baby reaches or crosses 2.5 kg. So until that point, the baby must only be sponged with warm water. Mother should also be taught on how to recognize the danger signs and where and how to seek urgent care whenever required. It is very, very important to drop a couple of emergency contact numbers to all mothers who are taking high-risk newborns home so that they can seek immediate medical attention. With the current advent of technology, it may be possible for us to offer even video consultations over, over online wherever it is appropriate and when parents stay very far away. It is also good to give an idea about when it may be appropriate to wean the baby from KMC, like when the baby starts wriggling out of KMC position, and when and where to return for follow-up. So a properly filled discharge card, which contains the clinical history of the baby, like the gestational age at birth, the birth weight, the problems which the baby had in the immediate perinatal phase, details of clinical management, etc., must be provided to all the babies at the time of discharge, including the date of starting of kangaroo mother care, the weight at that time, and the weight of the baby at the time of discharge, the mode of feeding, the duration of KMC provided by the mother in the last 24 hours, the type of milk given, whether it was exclusive breast milk feeding, any continued problems, and the line of management just before discharge, and the special medications if the baby requires any, such as occasionally when you discharge the baby on caffeine, and the nature of supplements such as vitamin D, iron, calcium, or human milk fortifier for eligible babies less than 1,500 grams, and the plan for the vaccinations given as well as the vaccinations which are to be given in follow-up. So I shall kind of summarize the key messages of this section. Planned early discharge is a special advantage and a very, very important component of kangaroo mother care. Mothers and family members should learn the signs of KMC as well as the care of low birth weight baby in the hospital so as to successfully continue the same care at home. A pre-discharge checklist must be maintained and must be complied in every unit, and the importance of the regular follow-ups and the plan to be followed in each follow-up must be discussed with the family. Dr. Sri Krishna, should I go on with the section on follow-up as well?
Yeah, a brief one, and we'll discuss it in detail on the workstation.
Right. Okay. So we shall now be discussing about very briefly about the follow-up of a preterm baby who has required KMC or who has been given KMC. So we shall be discussing why these babies require follow, what are all the kind of services offered in terms of where, when, and how frequently. What are the types of follow-up services offered? What is regular follow-up? What is meant by a special follow-up for high-risk babies, and how to organize follow-up services at tertiary care units such as district SMCUs and level 2 units. Now, why do we need follow-up? Obviously, follow-up is a very, very important component for all babies who also have benefited from kangaroo mother care, because one needs to monitor their general well-being, whether they are growing adequately. So we discussed at least a weight gain of 15 grams per kg per day is considered appropriate. So whether the baby is having appropriate weight gain, whether the baby is gaining, having head growth, whether the baby is increasing its length appropriately. And to also assess neurological development based on age-appropriate developmental as well as neurological sort of milestones. So how is the tone, or how is the baby's developmental milestones at various time points? It is also important to detect illnesses at early stage, such as, say, if a baby is failing to thrive. Early follow-up helps us to identify that the baby is having inappropriate weight gain or inappropriate head growth. Similarly, a baby with illnesses such as respiratory tract infection or acute gastroenteritis, when the baby is brought for regular follow-ups, the likelihood of this being picked up is much better. It is also important to ensure that the mother has actually understood the advices with regard to the administration of supplementary micronutrients. So very often you may find in follow-up that inappropriate doses of medications may be given simply because of lack of understanding, and also to ensure appropriate compliance to immunization. In every follow-up, it is again important to re-educate mothers and to reinforce the danger signs and to help them to seek prompt attention whenever required. Now, follow-up can be safely administered in the same hospital from where the baby was discharged. If it is not possible or if it is not convenient, one may refer the baby for follow-up at a more nearer hospital to the family wherever the facilities for follow-up are sort of available. Say, for instance, a trained pediatrician or a skilled community healthcare worker is available, where facilities for weight and monitoring of length, etc., are available. And you know that the other backup for ophthalmology and neurology support that a high-risk baby may require may also be available. So we can also refer them to a convenient hospital where appropriate facilities are already available. We have district early intervention centers, and these are ideal centers for follow-up. And whenever this is not possible, a home visit by skilled provider can be the next best possible option. So how frequently should follow-up be done? Before 40 weeks of post-menstrual age, the baby must have at least 2 follow-up visits per week, until 37 weeks of PMA. So if you are discharging a preterm baby who was, say, born at 30 weeks of gestational age, at an age of 3 weeks or 4 weeks of life, then the baby must be having weekly checkups during the first few weeks until the baby crosses 37 weeks of post-menstrual age, and then between 37 to 40 weeks of post-menstrual age, there must be again 1 follow-up visit per every week. Now, after 40 weeks of post-menstrual age, that is after term-corrected gestational age, then the baby may be required. The frequency of follow-up may be more variable. So you may want to see the baby at 3, 6, 9, and 12 months of age for neurological monitoring and for developmental monitoring. but the baby may be required to come more frequently if required. If there are any concerns picked up, then we may want to monitor the baby even more frequently, like say once in 1 month or once in 2 weeks also, if the baby has significant concerns. Typically, the babies are followed up until 12 months of corrected age, but some cases where you may have concerns such as developmental delay or poor growth, you may want to follow up the baby for an even longer duration of up to 3 to 5 years. So there is a follow-up checklist particularly when it comes to KMC. One has to note down during every follow-up visit the details about KMC session at home in the form of who is doing KMC, what is the duration of KMC at home, what are the details of breastfeeding. So how frequently is breastfeeding being done? Is the baby being exclusively breastfed? Is the baby passing urine adequately? Is any supplement being used? And how is the weight gain of the baby? Growth assessment, how is the head growth? And developmental assessment, which is done by using developmental screening tools at periodic intervals, preferably at 3, 6, 9, and 12 months of age. Wherever there are concerns on developmental screening, a more objective developmental assessment tool in the form of tools such as DASI, which is Developmental Assessment Scale for Indian Infants, or Bailey Scale, which is an internationally accepted scaling system, can be used for assessment of the baby's development. Now, we also should note down details of comorbidities or illnesses during or between follow-ups, say if the baby required hospitalization for infections, or whether the baby required hospitalization for any other complaints. Availability of sufficient stock of supplements, say availability of sufficient vitamin D and iron or human milk fortifier sachets, immunization, and it is also important to address any other random concerns that the mother may have. It is also important to schedule follow-up visits for monitoring other special senses, neurosensory assessment in the form of vision. Usually, retinopathy of prematurity screens are performed usually once in 2 to 3 weeks until 40 to 44 weeks of post-conceptional age. Subsequently, these preterm babies may also be required to follow up for one vision assessment between 9 to 12 months of corrected age. It is also important to evaluate them for hearing anytime after 35 weeks of post-menstrual age. So I think I shall leave this slide for everybody's view. So these are all the components of ambulatory care for a high-risk baby during follow-up. So assessment of breastfeeding, assessment of any other concurrent illnesses, ensuring compliance to vaccination, educating the family members as well as mother particularly. There may be high-risk babies who may require regular home pulse oximetry monitoring, particularly if the baby is extremely preterm, say born at gestational age of less than 28 weeks, or if the baby requires home oxygen therapy, and the need for early stimulation for babies who are potentially at high risk, say a high risk preterm, very low birth weight baby in the form of occupational therapy, or a baby who is developing signs of abnormal neurodevelopmental assessment, eye and ear examination, psychomotor assessment, and monitoring for regular growth. Weight gain in the form of 15 to 20 grams per kg per day. This can be plotted in preterm growth charts up to 40 weeks of post-conceptional age, and after term gestational age, we can very well use the WHO MGRS chart for plotting the baby's anthropometric parameters. So I shall, I think, leave this slide and stop here for want of time and hand over back to Dr. Sri Krishna.
Thank you, Dr. Aparna, for a wonderful session. So there's so much more to just doing KMC. The monitoring, the discharge follow-up, all these are part of KMC. Dr. Aparna, you can stop sharing screen. Right, now comes the interesting part. Ideally, if we were all in Bangalore now, what we would have done is we would have got up, stretched, we would have gone for a cup of tea, and then come back and then realize that we are all split into 3 groups and each of us goes to a workstation. We'll try to do something similar now. We'll simulate as much as you can. And while I do that, may I now request senior members, Dr. Rekha Udani and Dr. Koturesha, to please say a few words, and then I'll split up into the rooms as this happens. Dr. Koturesha and Dr. Udani, please.
Yeah, interesting to know things. What is the after preterm care, how it can be tackled well at the home, at the base level. And you should be able to appreciate the things they, when to follow up and how long to follow up. I didn't know myself because follow up to 1 year. I thought after discharge, hardly 3 months care to be taken. Now the analysis is up to 1 year. They have to take care of the benefit of the both mother side and as well as baby side. It's very much interesting topic for the, and I'm very happy for the faculty and all the participants. Good luck to everyone.
Hello.
Okay.
Very nice. Hello.
Hello.
Very nice presentation by each and every person. Really, I was so happy to see everyone taking so much of interest. Can anybody hear? Shri Krishna, can you hear me?
Yes, ma'am. Please go ahead.
So then everybody is so interested and so much going into the details of kangaroo mother care. So I am very proud that my all younger generations are really taking so well and doing, and I'm sure that they will give a quality kangaroo mother care. Just keeping baby for about 90 minutes or rather 60 minutes or 6 hours. No, now we have to go for 24 hours, but meaning that if you don't do it, your husband can do it, your any family member can do it, and that way we should be going so that 24 hours is done. I have seen in Bogota that baby is put on weight like anything, meaning that it is 15 to 20 grams per kg per day. No, they put on 30 to 35 grams per kg because all of them keep baby in KMC, and so 24 hours KMC. So at present, our aim is that each and every mother keeps baby in KMC for about 18 to 20 hours a day, meaning that the family take part. And then, of course, monitoring and other thing is there, and proper follow-up, because if you don't have a proper follow-up, like people are saying 1 year, no, it is still 5 years at the time when we had a KMC follow-up clinic. But our Dr. Nathali Tarpak has done till young age, means 20 years, 18 years follow-up. So then in that case, we need to now, our concentration should be good KMC, good quality KMC, 24 hours KMC, and at the same time, good follow-up. For that, we need to concentrate so that we can have a really wonderful and very intelligent baby. Thank you very much, Dr. Krishna.
Thank you for your thoughts, ma'am. And Dr. Kotresha, welcome. Now, what we'll do is we'll break up into rooms. It's exactly 3 o'clock, and we have faculty in each of the rooms waiting for you. What you need to do is just pause and look at the screen. Nothing else. None of the options will anyway be enabled for you. Just stay on, and you'll be able to just be allotted automatically to one of the rooms. After 20 minutes, automatically you'll be moved to other room, and you can join the other session, and it goes on. A request to the faculty, watch out on the time. I don't want you to have an unfinished session, so make sure you plan your session. And during the next 20 minutes, we'll have more interactions, and the faculty is going to speak less, and it's all going to be the participants who will do all the talking. So happy learning, and I'm sure this will be very exciting to learn for all of us as well. Yeah, so I'm opening up all the rooms, and I'll see you on the other side. Thank you all.
Sir. Sir, good afternoon, sir. Good evening, sir.
Hello?
First of all, unshare it first, close your share. Open the file if you want to share, and then again share. Start చేస్తారా? Yeah, start the slides and feeding చేయరా? Good.
Sir, rather, Yalesh,
1 minute, sir.
Sir, Yalesh, please unmute.
Just a minute,
Sir,
sir.
I think these are slides that are allowed to place. I think feeding babies is the topic connected to this one. Yes. మీరు వస్తున్నారా? యాదయ్య గారు.
I am coming, sir. Just a minute. 1 minute. Open it. 1 minute. You can.
Just a minute.
Here, contact this one.
Back to the-
Here, contact. Yes, please. Sir, I am disabled, sir. I am disabled.
ఫీడింగ్ కదా ఫీడింగ్ స్మాల్ బేబీస్ కదా
On, sir.
మన టాపిక్
On, sir.
అంటే నేను షేర్ చేయనా స్క్రీన్ స్క్రీన్ షేర్ చేస్తాను స్టార్ట్ చేస్తాను
Change. Shall I make my own presentation, sir? I have the presentation. I have made one presentation. You want me to, sir? I will make my. Yeah, I have the slides.
I have this file.
Sir, do you want me to start with my? Shall I do it with my slides, sir?
Start it.
Sir. Hello, good evening all. This is regarding the feeding of low birth weight infants. As you know, the low birth weight infants constitute about 14% of the total live births, account for 60 to 80% of total neonatal deaths. And these deaths can be prevented with, more importantly, providing the warmth, preventing infections, and more importantly, the optimal feeding of the low birth weight babies. Am I audible, sir? Hello? Yeah. Because low birth weight babies have a lot of handicaps, like immaturity of the gut by deficient enzymes and deficient absorption and utilization, and the motility problems, and also the immature kidneys were intolerant to high solute load and excessive sodium loss and failure to extrude hydrolyze. The difficulty in sucking, swallowing, and swallowing coordination with respirations. In the frequent illnesses in the low birth weight babies are respiratory distress and necrotizing enterocolitis and PDA and sepsis. And to meet the demands of the, sir, Sir, not audible, sir. Hello.
I'm saying I cannot. I'm saying
Sir.
that we cannot see a slide. Where are the slides? We cannot see.
Slides can be seen.
Are you making a PowerPoint presentation?
Yes, sir. I am making the PowerPoint presentation.
Then share your screen.
Yes, yes, good. This. Sir, I am disabled by the host, sir. I am disabled my screen. Host disabled my part as a participant. Sorry. I am not able to see.
Sir, otherwise, Sanjeev sir, you can share the slide and he can present. Yes. I think we'll go because
Sir.
we have 2 more batches.
Sir.
These slides are visible, sir.
Yes, sir. These are, for me it is visible, sir.
Yes.
Let's.
I think Yadav
Sir.
sir.
Sure, sir.
This is the first slide.
Sir.
Yadav sir, we can start.
Sure.
And whether participants can speak, they can interact with us.
So good evening. The assisted feeding for the small babies. The small babies may require assisted feeding to ensure adequate nutrition because preterm infants have feeding difficulties due to inability to coordinate, suck, swallow, and breathing, immature and sluggish gut, and systemic illness. The full-term small birth gestational age infants suffer from poor attachment and sucking efforts on breast, food swallowing, vomiting, regurgitation, and abdominal distension as if they are very sick. The assisted feeding technique may differ according to the weight and gestational age of the baby. Next. Next, sir. Next. Please, next slide, please. And methods of giving feed to newborns. Sir, you are going to EBM. First thing start is okay. Yes, methods of giving feed to newborns with small size at birth. It's more than 34 weeks, 32, 34 weeks, and 28 to 31 weeks. With the babies between 28 and 31 weeks, start the feeding by orogastric tube. Observe if there are vomiting and abdominal distension. And if the abdominal girth increases more than 2 centimeters from the baseline, and if it is no, then continue OG tube feeding. Otherwise, go for IV feeds. And if the baby is between 32 and 34 weeks, start feeds by spoon or palade. Observe if they are accepting well without spilling or coughing. If able to accept adequate amount, if it is yes, continue palade feeding. If the baby is more than 34 weeks, initiate breastfeeding directly and observe positioning and attachment are good. Baby is able to suck effectively and long and up to 10 to 15 minutes. Yes, you can continue the baby on the breastfeed. Next slide. Next slide. Then how often and how much to feed? Sir, any jump? Slides and jump sir. It's being jumped. We were at the method of selection of the feed. Now I am at the EBM technique. Sir, you do it, sir. Vijay Kumar, sir. Vijay, sir, please do it. You please do it, sir. What to feed humans with small size at birth? The best choice for LPW infants is mother's milk, and express donor milk from other lactating mothers. This is the second choice, and the least and this formula milk. Animal milk should not be used. There is no place for bottle feeding in the care of low birth weight babies. A very small baby, less than 28 weeks and less than 12 grams, IV fluids may be the better choice. Next. Sir, this slide is over, sir. Over. Next, sir. And how often, how much to feed? The baby should be fed every 2 hours. And this is the explanation. Every 2 hours, at least 12 times in a day. And fluid requirements are met by enteral feeds or intravenous feeds or both. And increased by 15 ml per kg per day to maximum 150 ml per kg per day by the end of first week of life. This is the list of table. The amount of fluids to be given depending based on the birth weight, that is more than 1500 grams and less than 1500 grams. Next. Next, sir. Next. Sir, this is a lot of an express breast milk. Infants are able to feed. Sir, sir. The problem is, sir, Vijay Kumar, sir, you present it, sir, better you have the slides. Vijay Kumar, hello? Please go ahead, sir. Sir, you please carry on, Vijay Kumar, sir, it's difficult. Sir, మీరు చెప్పేయండి. Vijay Kumar sir, you please carry on.
Yes, sir. So the ultimate aim of feeding small babies is to ensure direct breastfeeding. Rajesh sir already told us there is no role of bottle feeding. Are you hearing me, sir?
Yes, sir. Audible.
Right. Then our idea of feeding a small baby is again breastfeeding. There are arguments that have told us express breastfeeding, breastfeeding from a donating mother, a formula milk, and that's all. Not bottle. That is very clear to us. Yes, sir. Whether you people can any participants can whether you host us, I'm able to unmute. Anybody please try. Anybody plus? Yeah. Yes, sir. So, what are the alternate oral feeds is the tube. Sir has already shown us. Yeah, is tube for very small babies, food, melody, and gum. There are two things here: sticking reflexing, swallowing reflexing, and making food. Sucking and swallowing reflexing. Both are not there. They will small baby. That can be taken. Both swallowing and sucking reflexes are not there. Then we use a tube. That baby can is small to suck, but baby can swallow. There we give spoon after baby. For the spoon, melody is a mistake. Melody by spoon, with spoon, the spilling is spoon. Spilling of the milk is spoon, and really baby is hungry, and even the caretaker is not satisfied. Mother is not satisfied. So melody is the best way. Is not because it is traditional. Melody might put the spoon. So the cute spoon after a day, we should be given treatment after the suckle and the breast before the next feed. check it. There are some nurses in the room. There was a critical practice of you just take out some missing and there is some milk. Say, people used to postpone that. That is not there. None of us will do this part. We will not check how much the stomach is full. So, give small intragastric feeds, and if the baby is already there is no baby is not dull, no abdominal distension, baby did not vomit this, vomit is not yellow, then we will go with the next feed. The same quantity or little more quantity. And adequate urine output is a very, very important sign of the adequacy of feeding that we are giving. For a small baby, the baby is getting spoon feed or pellet feeding in whatever SR again told us that every 12 hours we will give, every second hourly, and he has given example. If the baby is getting adequate feeds, of course we do daily weight gain, daily weight recording we do, but even such thing is, when the baby is passing urine 8 to 12 times a day, it is a very good sign of adequacy of the baby's weight gain is 50 to 20 grams per day. These are the two very, very important signs of adequacy of the food that we are giving. The baby is passing stamping urine, or if the weight gain is not less than 15, this is not adequate feeding. Or specialists should say, is there any other reason for it? It can be said. I think if there are any questions, I don't know whether they can unmute, sir. Sorry? I don't have short so, let me invite Dr. Rekha is Dr. Rekha, are you there? Invite Dr. Rekha for comment. Yes. Hello. Yes, sir. Yeah, sorry. हमारा group पर technical something, but we just continue on some comments from before the group closes. Over to you. So, the part of this particular school, I would like to say whatever person is done very well, but to add into this, it is very important that we give non-native to take number one and number two. Now people are doing the swabbing of the mucous membrane in remote school, which is a tremendous advantage of the development of the and third thing is protecting. I thought I would like to say number one is all of us are now in plenary.
I've brought everyone back to the rooms. Now what we'll do is I'll have to put you all into the other rooms. Any specific difficulties? I know it's a very short time.
Actually, Shri, Dr. Yadaya changed his ID, so you made him co-host.
Yes. It becomes very difficult for us if faculty join in the last minute, and I've been repeatedly saying that as well. And I'm making the concerned people co-host now. Request all the faculty to please stay on as co-hosts. It will be difficult for us to manage if you log in after you break out rooms. And same with Dr. Satish as well. please stay on and request your presence for the next 2 sessions as well.
I'm available.
Right. So just giving you a minute break, and I hope everyone else is also available. Now, what we'll do is we'll be moving
You will be moving
the entire segment.
resource persons, or you will moving participants?
No, sir, only the participants will be moving. And
Whether participant can speak.
yeah, so we'll be moving you to the other room.
Dr. Krishna, whether participants can unmute.
Yes, they can.
Definitely, sir. In our room, it was the participants who were speaking. I was only facilitating.
That's what I wanted. That okay. This time I think I'll take care of it.
In fact, the slide needs to be put up by the faculty. It's the participants who read it out.
Yes. I think now we'll do that. Yes.
Definitely.
Yes.
Okay.
Yes, sir. Thank you.
I'll be moving room 1 to 2 and 2 to 3.
And move me to some other group, other room.
Sure, sir. Yeah, co-hosts can always move around.
Dr. Shri Krishna,
yes, sir.
can I just have a minute to share one of my photos? It's okay for this. So here I'm showing you my son. He was born slightly low birth weight. I won't say low birth weight, but yeah, he was born 2.2 kilos. So we followed, me and my wife together followed the KMC. We almost did for 18 hours, except for washrooms and late night sleeps. We never put the baby on the couch. We always followed that cap, mittens and gloves principle. Within 1.5 months, within 15 days, you can see him that we are following the mittens, caps and the gloves thing. Within 1.5 months to 2 months, he caught up good weight. From where? By the end of 3.5 to 4 months. This was around at Vinayak Chavti. So May to August. Like in 4 months, he had put up more than 35 grams per day. So that was my experience with the KMC. And I'm very glad to see you all promoting it at a massive level. Thank you. Thank you for the opportunity.
That was very, very good, very motivating, very short personal presentation, real lifetime. Thank you, Satish.
Thank you so much, ma'am.
So request you all to join your rooms. There'll be a little confusion, but in case you are in the same room, just reach out to me and I'll try to shift your rooms. Request all the faculty to please stay on. If you keep logging off and logging in, this session will not work. And it will become very, very difficult. Thank you. Himabindu madam, you may please start the session. Very little time you'll have.
In my room, how many participants are there? Okay. So am I audible? Am I audible? I'm not able to hear anything from the participants. Hello? Hello? Am I audible? Okay. So I'm going to demonstrate once again the KMC here. This is the KMC ward. I just want to show all the participants. This is at Nilofer Hospital. We have a KMC ward. We have a KMC ward. Are you able to see? My ever photo chindi?
No, ma'am.
No, you're not able to see. Yeah. Okay.
No, ma'am.
So this is the KMC ward at Nilofer Hospital, which is the tertiary care center at Telangana. So as there are 300 newborns being cared here at Nilofer Hospital. So this is a dedicated KMC ward. As you can see, all these mothers doing KMC and including family members. So we also have a television actually to show the audio visuals of KMC. And you can see so many parents are doing KMC here. So they are twins, even fathers and grandparents are also doing. So now we'll just demonstrate how to do KMC. So first, this is a mother who has a newborn, who's 20-day-old now, 1.1 kg. 1.1 kg. చూస్తున్నారు ఓకే మీ బేబీ ఇక్కడ ఎన్ని రోజులు అయితే న్యూబార్న్ ఇక్కడ యూనిట్ లో స్టేబుల్ గా ఉంది కదా ఓకే we need to first do a proper hand wash, and I have already done that. Sanitize your hands. Talk to the mother. This mother is willing. Can you just give me this baby? You have to prepare this baby. You can see this. This baby is having a topi. We put the topi to the mother, to the baby, and two socks and a napkin. And this baby acts on with intracat. And you can see this. There's nothing. And this baby is for KMC. So we just position. The mother is wearing a nightie front open. So we place the baby onto in between the breasts of the mother. Okay. So in between the breasts, hold the neck in a frog position. So like this, both the legs are like this tight. Support. So with legs నిల్చుంటారా నిల్చొని కూర్చోబెట్టడం so just tie again. So this baby head neck is supported. We use another sling. To give a support at the back below. So this baby's neck is slightly extended. The mother is able to see, and this neck is supported. Tight karo. And you can tight rendu kuda tight. Okay. So pattukogaltara. Are you free to? How are you feeling? Happy, comfortable? Yes. Okay. So now you can just walk and demonstrate. So she's free to walk and talk, do her routine things. So you can see her twins. This is the father who's doing KMC. There's another baby who's a grandmother. She's also does KMC. So she can take rest on a KMC chair. This is a KMC chair. So she can take rest. Mother is able to take rest. Are you comfortable? You are comfortable? Yes. हाँ. So how are you feeling? What is the weight gain? कैसा था? 80 grams. 80 grams. अच्छा. So any register you are maintaining? Huh? Any register you are maintaining? What is the name of? Yes. So how much weight gain? 80 grams. How many
Right. Good afternoon, everyone. Hope you're all back to the main room. Now, are you able to join any room which is, I have enabled that setting, but let me see if you can join any of the rooms. I will leave it manually to you because you will remember room 1, room 2, and room 3. Room 1, we had Dr. Himabindu Singh and Dr. Satish demonstrating live on a mother about KMC. Room 2, I was there telling you about the monitoring checklist. And room 3 had Dr. Vijay Kumar and Dr. Yadeya. So I'll try to enable the settings so that you can shift to whichever room you want to. But that requires you to be actively be there. Himabindu madam, any concerns in your room?
Yeah. Actually, I was seeing that 6 members couldn't join. They were.
Yeah. The problem is once you leave the room, it is very difficult. I need to come and then enable them to join.
They have to click some square.
This is like a physical setting. Once you leave the workstation, it is deemed that you're out. So if you're active and involved in the workstation, then see the rest of them, they are able to seamlessly join. And Vijay Kumar sir, any problems at your workstation? And Yadeya, are you now able to? I don't find Yadeya sir here. Satish, were you able to share the video?
Yeah.
Hello? Yes, sir.
Yes. So now what I'll do is I'll see, because it gets a little confusing with people coming in and leaving. I'll see if I can shift people into the different rooms. And
देख लीजिए फिर मैं आपको बात
right. So now I'll move you. Room 3 will go to room 1. People who
I did not keep all those
with me.
pictures with
So
me. Otherwise, I would have shown you
just
that
take
it
a
is
little breather
possible
as I settle
to
this.
done it all. And then only
Thank you, madam. Thank you, madam.
wait.
Thank you, madam.
Okay.
What's happening, Sri Krishna?
Madam, you are getting people into your room, ma'am. I'll just open up the room. I'm just giving a minute breather so that they can just join. Okay. Right. So I think room 1, people are already in. So I'll be shifting room 2 into room 3 now.
और हमको श्री कुछ भी समझ नहीं आ रहा है जो तुम बोल रहे हो ना.
Sir, you just get allotted to the rooms. Make sure you are in a different room. That's all that matters. Sir, you have been to room 3 already, right?
3 and probably इस बार तुम्हारे वाले रूम में था वो. I don't know.
Yeah. So
now 3 hai, sir. First one was 3. Sanjeev sir with us.
So now you get allotted to room 1.
Okay.
Yes. Yes. Please go ahead. And
how can I move to room 1?
Who, sir?
Dr. Ashish.
Dr. Ashish, I'll move you. Just give me a little time because you need to be a co-host. If you're a co-host, then I can move you to room 1. You are currently in room 3 now, right?
No, I don't see anything here on my screen.
Okay, just give me some time and
Okay.
1 cent, just a minute, and then we are all good to go.
Many are asking that their rooms are not changed.
Sir, I did not change, sir. I need 1 minute to change.
Okay.
So give me some time so that
Sure.
I'll be able to move you all.
Ji.
Yes, yes. We are in the process of doing it.
Nice. पूरे श्री कृष्ण अपना गॉड है, गॉड फादर. आप जो बोलेगा सुनना पड़ेगा.
Yeah, and there may be 1 or 2 who just get allotted to the same room. So I'll try to get you back to that room. Don't worry.
He's like a hostel warden, Dr. Emma Bindu. You can put anyone into any room.
Yeah, and this is also your tea break. This is a time when you just get up, stretch a little, and then by the time you're all ready, I'll get you back. Okay, so there will be a few who are in this room, that room. Again, just leave me a message. I'll try to get back. Let's start. So message to everyone, in case you are in the same room or tell me which room you have not been to, I'll try to put you up. It would have been easy had we named it accordingly. Unfortunately, we couldn't do that. So if you want a specific room, please let me know. For example, Roja has been in room 3. So just put up your room. Shalini, I'll put you into room 2. Welcome back, everyone. So, may I now request the co-hosts. Hope it was an enjoyable experience. Nothing can beat the joy of doing it in person, looking at each other. But I hope we all had some fun. Dr. Satish, how was it? Any hitches in your room? Unmute చేసుకోండి sir. Yeah.
So, yeah, the first best thing is the team is as bright and vibrant as the team leader. So you are the best organizer and the team leader, I suppose. Full of energy, full of enthusiasm.
Team is as good, not the
Right.
captain, sir. Team is as good as the players. And thank you to all of you. I know it is very tough because I have already put the limit. You can't even say, give me 1 minute more. You have to finish in that time. And nothing is in my hands. It's all technology. It's all done.
1 minute. I want to congratulate Vadapali, Satish. He really did a wonderful job. Congratulations, Satish.
Thank you, ma'am.
You have done yourself and it was really good.
Himabindu madam, how was the room 1? Were you able to demonstrate? And I'm so sorry, the computer will not listen to me if you want 1 minute more also. I have to finish.
No, it's okay. Finished.
Ma'am, unmute yourself, Himabindu ma'am.
Actually, I had to go down to the ward and I came back to my chamber. So it was a very good experience. Virtually, आप क्या क्या करवा रहे हो? It was. I wanted to interact with the participants. And the third time I could interact.
Yeah.
Third time I was able to interact and we were more comfortable.
In fact, we do this workshop the third time, we'll get everything perfect. So I'll request KMC Foundation, Dr. Nikhil is also here to please organize more such workshops so that we become perfect in all this. Welcome, Dr. Nikhil, and without wasting much time, I now hand it over to you. So we have another 40 minutes and I promise to leave you all by 5:15 sharp. Over to Dr. Nikhil to take us through his presentation. We have seen from morning the science of KMC, the art of KMC, monitoring of KMC. We did a little visit of the KMC ward in a virtual way. We saw how do we monitor KMC and then expression of breast milk, a few skills. Now we hand it over to Dr. Nikhil to take us through KMC beyond the hospital. What else do you do once you are done with doing KMC at the hospital? What comes up next? Over to Dr. Nikhil.
Right. Hello, everybody. One minute. Can you see the screen?
No, sir, it's not there. You're a co-host, so you can share screen.
Yeah, I'm trying to do it. I think I need some help. Okay, fine.
No, sir, we can't see it. So you'll have to go to share screen and from there go to the presentation.
Yeah, I'm doing it.
Yeah. Now it's coming up. Yeah, right. Over to you. Make it full screen. You have 20 minutes.
Yes. Okay. So it's very wonderful. I've been with you since the morning. In fact, since the beginning. Only thing, my computer is the office computer, so I wasn't identified, but I was very silently watching all of you and enjoying the show. And for me also, it is a very new experience, going into the breakout room and then coming back and so on. Exciting. First time I'm attending a workshop like that. On behalf of the KMC Foundation, I'm very happy to share a few things with you. So far, we have been talking about KMC in the facility, and the concept originated in the hospital. But as you know, we are working in a different scenario. I am working in rural area, and we know that majority of the country is rural still. 60 to 70% of the population is rural, and their facilities are very limited. If you look at the scenario, this is what we see very often. and we have to rely on care at home for salvaging large majority of the newborns. Particularly, even in COVID era, people are very afraid of going out, going to the hospital. And even if the government schemes have facilitated a large number of deliveries at the institutions, to keep them in the institution, in the facility for more than couple of days is very difficult, and therefore we have to rely on something at the community level. Of course, I've been hearing about states like Andhra Pradesh, Telangana, and Karnataka since the morning, and they are doing wonderful work. But for majority of the areas in our country, still facility-based care is a very, very remote dream. These are some of the statistics, although they are not very updated, but by and large the situation is still same. And we boast of a lot of world records, and these are some of the world records that we are having. Look at the number of births, the number of neonatal deaths, low birth weight, preterm, stillbirth, maternal death, and so on. And there are wide disparities between urban, rural, poor, rich, gender, and so on. Gender is also a very important issue in our communities, where particularly when twins are born, they would prefer a boy to be looked after better than the girl, and so on. So we are facing a lot of challenges, and the COVID pandemic has compounded the problem. Developing countries contribute 99% of the neonatal deaths, and from this, India itself is about 25%, and majority, more than 50%, occur outside the facilities. Even transit also, many newborns are dying. We don't have exact statistics about the deaths during transport, but we know that this more than 50% includes death at home as well as during the transport. And therefore, we have to think about some alternative strategies. Now, the kind of problems that we face in KMC implementation, of course, we have the national policy which promotes KMC for all the babies of about 1.5 kg was stable and so on. They are also promoting creation of bonds, but still we don't have enough trained manpower. We don't have even pediatricians who are confident or interested in providing kangaroo mother care in a big number. It's not a very glamorous thing to do. General perception of the doctors is that it doesn't yield too much of income in the private sector. And I think Dr. Ashish Mehta, whom I am able to spot here, he might be able to throw some light on these kind of issues, later on. There are very poor facilities for mothers, and if they have to stay in the hospital for a prolonged period, they need even a decent place where a little bit of privacy and comfort can be provided. We have to have adequate counseling and supervision, and so on. So there are many hurdles due to which KMC is not being implemented uniformly across the country in the facilities. And therefore, we think about home-based or community-based KMC. It could be a very useful and advantageous proposition because at home, the cost of care would come down in a resource-poor situation where babies are stable and do not need too much of hospital observation and treatment. They can be looked after at home. Similarly, if you train them well, the community health workers can provide good quality home-based kangaroo mother care. We have had some experience over the years, and even one study was carried out with the help of ICMR, and we have shown that a team of well-trained grassroots workers like ASHA, they can provide reasonably good quality KMC. We could reach up to 5 hours per day and could salvage most of the babies, except 1 or 2 out of 101 babies that we had given KMC in the community. And they included some babies who were even less than 1.5 kg. So if you train them well and supervise them, these workers are a very good workforce for improving the newborn care and also provision of kangaroo mother care. So it is fairly safe and it has all the benefits that you observe in the institutional settings that also we had seen in the study. And the acceptance was also quite good. So there are now studies which have shown that home-based or community-based KMC is acceptable, and if implemented properly, it can be a way out where we have a lot of monumental problem in improving the plight of our newborns. Now, if you think about the overall scenario, there are 3 tribes, 3 groups, of babies, that we have to think of. First group is delivered in the hospital. KMC started in the hospital, and after a planned discharge from the hospital, subsequent care, including KMC, is continued at home. Now, this is a kind of situation that exists in maybe Telangana, Andhra, and Karnataka, but at present, this number is not very high. The second group is fairly big, perhaps biggest of all, delivered in hospital, KMC not started in the hospital, and even though indicated, and then the baby goes home and there we, with the help of community workers, we start. Now, this is the largest group in our area right now because institutional deliveries are universal, almost universal. But KMC doesn't occur. Even in government setup, it doesn't start. Private also, we are facing a lot of problems. Home deliveries are the third group, but in some northern states, even this number is also quite big. So this group 2 and 3 is more common. The target group, but even here also, if we can motivate our doctors to start KMC in the hospital, the task can be to that extent eased, because whatever good practices that happen in the institutional setting, they will be easily accepted by the community. And even though they cannot be kept in the community for a long time, the care can be continued with the help of link workers at the community level. Now, the advantages of home-based KMC are also very significant, because you can reach out to a large number of low birth weight and preterm babies who are stable and who are otherwise deprived of quality care because of provision of the kangaroo care at home. It reduces the cost of treatment, and the burden on the hospital is reduced considerably. And this is a very significant advantage in our situation, because we don't have enough resources to deal with large number of preterm and low birth weight babies. We have also seen in the morning that neonatal mortality is reduced drastically by KMC, particularly more than 50% of the low birth weight babies, the deaths can be prevented by good implementation of kangaroo mother care. So overall, it is a win-win situation for everybody, and it is worth giving a try. And I think this is the way to improve the plight of newborn in our country. We do need to take care of a few things. We cannot just implement KMC in the community without some inputs. We do need to train community health workers properly. Particularly, these workers should be skillful. No point having just the concept, but skill is very, very important. They should also be trained to provide care with the full knowledge of their limitations, and therefore they must be aware of the link, referral linkage, where they could send babies in case of any emergency, and also know how to transport these babies, which I am going to talk about a little later. So community health workers can play a very important role, because they are the ones who can influence the community very easily. And if they, start counseling and educating people beforehand, then implementation becomes easier. So finally, the attitude is also very important, and this could be a problem in some areas and may not be a problem elsewhere. But overall, I think our experience has been that the community-based workers, if given opportunity, they are very eager to help out people, and therefore, if we motivate them and give them enough training, they could be a very useful help. Who can be given home-based KMC is a question that very often arises. And I think the simple answer would be all the babies at least more than 1.5 kgs, 1.5 kg birth weight, and who have no danger signs. I think here we can teach them the identification of danger signs and pick up those babies who need referral immediately. And the rest can be given home-based kangaroo mother care. In our training, we also include, monitoring for the signs of serious illness and some immediate care points, and also referral. So in community setting, if we focus on the proper screening, I think we can implement. And majority of the newborns without danger signs can be looked after at the community level. Sometimes in the community, this may be a problem. Identifying a preterm baby or a low birth weight term baby, or full-term baby, or appropriate weight baby, because weighing scales may be a problem. So we can rely on simple criteria, and even if they give KMC to every newborn who does not have serious illness, nothing is going to be lost, because anyway, skin to skin care for all newborns, is a beneficial thing. So this should not be a limiting factor. These are some of the examples where community worker is helping, and this is the kangaroo sling that we are using in our area. The one which Dr. Hima Bindu was also showing, this is, it was earlier used, initially used by KEM group, and then Vani madam modified this, and now we are using it in our area. These are the twins who were less than 1.5 stable, and the parents had no resources to access. And in those days, about 1 decade back, there weren't even facilities in the government setup where they could go and get the treatment, and the community health worker, helped them with kangaroo mother care. This much about the home-based care. I am just making a point, an advocacy point for home-based KMC. The training can be organized properly, and we can take up this on a larger scale. A few slides on the transport. Outside the area of facility, this is the second major, aspect of newborn care where KMC has been found to be very useful. Now, the objectives of care during transport would be, as highlighted here, warm environment, adequate oxygenation, nutrition, an environment which is supportive to development. And this is a very important concept which I am going to elaborate a little later. And of course, during transport, you should also be able to observe some vital parameters. Now, in the transport that we, even with 108 network, we do observe problems like hypothermia, hyperthermia, hypoglycemia, hypoxia, and also the environment that I am talking about. These are the major issues that we come across in transport in newborn. And I think I'm sure everybody who's working in a big hospital has similar experience that whenever the babies are referred from outside, to NICU, they are received in hypothermic or hypoglycemic or hypoxic state. Due to the stressful environment now, they've shown that it can affect the vital functions significantly, and therefore we think about some alternative approaches. Now, the calming techniques that we can think of in the newborn, even during transport, could be one of these, and of course, the most important, kangaroo mother care. Now, KMC during transport has many advantages, like the vital signs are more stable in KMC transported babies. Bonding is also one of the advantages, and also breastfeeding. So it promotes a very healthy relationship between mother and the child, and also the physiologically the child is a study which is very often this is a study which is sorry, and babies weighing ranging from 1.2 to 3.7 kg, traveling a distance 2 to 400 kilometers, traveling time 10 to 300 minutes. All these parameters were stable throughout the transport, and the parents were very comfortable and safe during the transport. So, KMC transport is more physiological way of doing it. You may have in a facility without a specific binder. You can use any other method, sling, tari, whatever. But the babies need to be secured during transport. Here there might be a case for using a suitable binder or a sling, and these are some of the examples. The KMC Foundation has been working out with the concept of coming out with the guidelines, for KMC transport, and this was one of the points which we had discussed a few days back. And I think during the conference we may have a presentation on the consensus that we reached during the meeting. In West, you would find something like this, a transport which is very non-hazardous for the newborn and less damaging, and therefore doesn't add to the morbidity. In rural areas, sometimes stable babies who are low birth weight can also be transported like this in kangaroo position. This we observe in our villages sometimes, even today. So this is Bharat and not India. But please remember, community awareness is the key, and we have to educate community about everything and generate enough participation. We need support, because we find that family support is one of the most important factor which decides the effectiveness, adequacy of kangaroo mother care. Thank you very much. This is all that I had to share. I just tried to, create a case for, promotion of kangaroo mother care during transport and also at the community level. I am sure I have made my point, and if there are any questions, I will be happy to answer.
Thank you, Dr. Nikul. Could you please stop sharing, sir?
Yeah, I'm just trying to look at the
yeah.
Okay.
So
any
that
comments?
gets us to the last session, and I'll take you through quality in KMC, and I promise to finish on time as well. So last session, and request your kind attention. And there's a very interesting concept of quality in KMC. Whatever we do, it's always nice if you are able to offer a better quality. It's nice if you can move from good to better, better to best. And this quality, we want it all the while. You want a good quality car, a good quality dress, good quality healthcare. That is what we're all looking for. Good quality KMC as well. Why not? So let me take you through two terms. Quality, when I'm talking about quality assurance and improvement, and these are different. How are they different? Quality assurance is referring to a certain set of standards. You try to rely on inspection and see if they are as per the designated standards. You focus on what is supposed to be present. Is it present or not? And quality is a separate function, and a particular department is in charge of doing it. Quality improvement is a little beyond this. It focuses on improved performance. And as I said, it's trying to move good to better and better to best, and to sustain the best and try to get to a level where you motivate others. This requires monitoring over a period of time. It is orientation of the system and the health system strengthening, and quality is integrated into the organization, and it involves all the disciplinaries. Quality is not possible as a QI if you're doing it only alone. So the QA model focuses on the outliers, the ones who are weak. You try to just focus on them and try to get them to pass. So this is like you have a pass mark or a distinction mark and you need to cross it. QI model is where you look at 10% hike in whatever you get, or a certain improvement based on the targets that you fix. So it will identify substandard care, QA model. It will give you determinants on competence, and you have a variable process, and you capture the overall data, have an overall score, and then take corrective actions. A QI model is to shift the curve, standardized processes. The measurement is your goal, and you have aggregated data, and you will learn more about QI as I speak. Now, let me take you through QA of KMC. How do you assure good quality KMC? How do you know that the KMC in your hospital is a good KMC? For that, there are certain principles, and I'm taking this from the KMC Foundation, this poster. Implementation of proper policies, selecting the right newborn for KMC, counseling the mothers, preferably with the family members, demonstrate KMC by another mother. This is another nice way of doing it. Select the good place, prepare the mother and the newborn, use the correct garment, and ensure it's always breast milk for every baby who's on KMC. And other steps which ensure good quality KMC are monitoring during KMC position, ensure that no baby is in distress or has any untoward incident. You'll be able to pick it up early if you can have a good monitoring. Document record keeping, ambulatory care, and not just at facility. As we have seen, try to continue it beyond facility at home as well, including in the transport. All these are components of good quality KMC, wherein you are ensuring that a certain services are assured. What is QI then? What is this new term which we are all hearing all around us, quality improvement? So quality improvement is a way in which you are improving the quality through strengthening the health systems and identifying weak areas and trying to work on them. It's as simple as that. We do it all the time. We do it in our kitchens, in our houses, in our cars, in our laptops, in our presentations. We do it. And the same principle, we're trying to do it for KMC as well. And I'll take you through that. So QI approach has got 4 steps. You identify a problem, you form a team, you write an aim statement, which is a SMART aim, you analyze and measure quality of care, you develop and test changes, and then you try to sustain improvement. Sorry. So let me take you through a small project of QI on KMC. And this is from the POC QI learners module, wherein we have tried to improve the quality of KMC in the NICU. And I'll just give you a 5-minute gist of what exactly was done and what was the result. So the background of this particular newborn unit was that this was a NICU like any other, wherein KMC was initiated for all the preterms and the LBW babies as soon as they become hemodynamically stable. And ideally, the KMC should be practiced for 24 hours as per WHO recommendation, but it was found that they were not able to fulfill that norms. So their problem was they were not able to give KMC for an adequate duration as desired. So they created a smart aim where you have very clear measurable target in a defined period and something that is practical and doable. So the smart aim of this particular project was to increase the duration of KMC practice of LBW infants. Again, you have a from and a to. You know where you are moving from and where you need to go up to. So it is from an average of 3 hours a day to a minimum of 6 hours a day. And how long? You can't do it overnight. You can't just wait forever. So over a period of 2 months. So this is how a smart aim is built. And then you need data to back you. You need data to tell you where the things are going wrong. So you have a data collection plan wherein the demographic profile of the baby and the mother, the weight and gestational age, the age at which KMC was initiated, questionnaires, along with that, the team members. It's not enough if you just want to do it all yourself. You need a complete team who is committed and has the same work style as yours and are ready to put their efforts together. So you form an effective team with nurses as the lead, and then you analyze the problem. We do it for all our other works as well. The same has been analyzed in this particular newborn unit on why KMC is not going on for 6 hours. Why is it that we are not able to reach that? They realize that we are not doing any postnatal counseling. Mothers are just being given babies and being asked to do KMC. Baby is sometimes becoming hot during KMC. Maybe that is not the best position or the place for the mothers to be. It's a stressful environment and no mother likes to do it in front of everyone. Who really would love it? So lack of privacy, lack of confidence, the mother being anxious, and the mother's knowledge, aptitude, skills, they're all an issue. And because of all these, the mother is not able to do for a desired amount of time. And once you start mapping all this, what does it help? It helps you to target that specific area. If it is a lack of knowledge and the postnatal counseling not happening, you'll be able to take up that particular intervention and then things will get better. Lack of support from the healthcare team, no proper counseling, lack of privacy for mothers, lack of accountability of the assigned nurse, lack of knowledge, confidence amongst mothers. All these have been identified as the major barriers. Next, what do? You do a PDSA cycle. You plan, you do, you study, and then you act. You plan to collect data which is baseline and also on the program. What do? You take up PDSA cycles. You take up in the first cycle counseling, for example. The second cycle, you try to change the infrastructure a little, make it more convenient to the mother, ensure privacy, better skills for the mother. What do you do then? You then study. You study how your thoughts, your intentions, are they getting converted to actions or not? You also know whether this can be applied on a large scale. You analyze data to study the duration of KMC for each baby and who is giving KMC. And then last, you will act on it. Continuously, this process goes on, and you will ensure that whatever decisions are taken, they are sustained over a period of time. I'll now take you through what this particular newborn unit did during their QI on KMC. So the first week, they realized postnatal counseling is a major barrier. So a team of 4 dedicated nursing staff in different shifts have started to counsel the mothers. They used whatever resources they had. They showed a video. They spoke to the mothers and slowly started to realize that there is some change in the mothers. the more you communicate to them and understand their concerns and answer their queries, their acceptability is much better. And they have motivated other family members also to do KMC. Then this was week 1, and they had a very comprehensive postnatal counseling. The second one was PDSA cycle 2. In week 2 was to encourage nurses to ensure KMC for at least 2 hours per shift. And after a period of time, you somewhat get a little exhausted, burnt out. And that is where motivation and the commitment of the unit and how well you gel as a team comes in. So felicitation and provision of a certificate of appreciation to these nurses who put in these efforts, that went a long way in ensuring that these staff are motivated to continue this for a sustained period of time. Promoting a supportive environment for in the NICU for KMC, and then making sure the mothers are involved in the KMC as well. Then week 3, we looked at round the clock availability of nursing staff for babies on KMC with some form of respiratory support, and this ensured that their work also came down. Otherwise, this baby was probably on oxygen in the warmer. Now, this baby is on the mother's side with the nurse ensuring her task responsibility is shifted to the mother. So this is how they have shown that they have been able to increase the KMC hours over a period of time. The average KMC hours per day has also increased, and 70% of the mothers have been shown to do KMC for more than 5 hours in a day. And the longest hours of KMC achieved in a day, that has also increased. This was a very small amount, 1 or 2 hours. Now it has come up to almost 10 hours in a day. So like this, you are able to convert the same resources, energies that you have to make a much better quality of care in the KMC ward. So after you have shown that this is working well, what are the steps in sustaining KMC in the post-implementation phase? You need to involve the family, ask the father and the close relatives for doing it even at night, assign responsibility of an assigned nurse, make it a part of their daily doctor's treatment order, and continuous encouragement and reinforcement. These are very important in showing sustenance. And what are the lessons learned? Simple measures like active participation of family members, continuous positive reinforcement from the team, all these have a significant effect in improving the quality of KMC. And this will ultimately reduce the infection, improve bonding, and we know all the benefits of KMC. So the conclusion is the average duration of KMC increased from 3 to 6 hours in a span of 8 weeks. All the mothers started doing at least 6 hours of KMC, and active involvement of the mother as well as other relatives resulted in a sustained increase of duration of KMC. And this is how all these processes at each step, if you are able to ensure good process and map it and implement it well, you will be able to ensure good quality KMC. Thank you everyone, and that finishes all the technical sessions for today. Now, any queries, any questions, request you all to please post it in the chat box. It's been a very interactive breakout sessions, but anything from the morning and obviously the community KMC and the quality KMC, request you to please post your questions in the chat box. We'll quickly take up the closing remarks after this, but before that, I'll have to put up the poll. And yes, Nirmala had raised her hand. Nirmala, you can unmute. Please speak.
Sir, can I ask in Hindi?
Yes, please.
Sir, suppose baby low birth weight है community settings में.
Yeah.
तो हम लोग उसको कटोरी स्पून फीडिंग कर रहे हैं. कटोरी विथ स्पून फीडिंग दे रहे हैं मदर का ये एक्सप्रेस ब्रेस्ट मिल्क. तो मतलब फ्रीक्वेंसी कितना होना चाहिए, कितना ड्यूरेशन में हम मतलब बच्चा को हम लोग फीड करा सकते हैं सर?
Hello? Hello? What happened?
Yeah, I'm so sorry. I had to log off. Hope we got your question answered, Nirmala. Right. Now, what we'll do next is I'll try to relaunch the poll, and I hope you all can see the poll on your screen, and request you to please answer these questions. And these questions are all picked up from the presentation through the day. And as you answer this poll, I'm going to allow participants to mute themselves and mute and unmute themselves. Can we have a few remarks and feedback from the participants? May I now request senior members, Dr. Rekha Udani, ma'am, if we can have your comments to begin with. Shanti from Vijayanagaram. And anyone else who would like to interact and share some feedback?
I'm Dr. Aditya Mahapatra from Odisha.
Yes, sir.
I had been there from 2 o'clock. Actually, I enjoyed the workshop. This is really very nice, nicely organized by you. So very much thankful to you that you have developed such type of framework. If you can share these PPTs and checklists with others so that we can organize the workshop in our state, and we can do it in our rural areas. And very informative. Dr. Nikhil lecture was very informative regarding home-based KMC. And though I have practiced in rural areas of Odisha, still I have to get the result. And at last, the quality improvement topic is very good. And I will try to assess this PDSA cycle, and I can hope I will improve in Odisha. Thank you very much.
Thank you, Dr. Aditya. Dr. Shanti.
Sir, I feel KMC is a very important component, especially in the preterm low birth weight care. And conducting a conference like this will emphasize the importance of kangaroo mother care. People may get excited about surfactant therapy and things like that, but this gives a comprehensive care for the baby, and all the topics are covered very nicely. And it's a very useful conference, and it is very nice, and it's very useful for the practitioners and also NICU doctors and staff and everybody. If everybody is determined to do it, and it is possible, and all the preterm babies will get the benefit of it. I congratulate the Sri Krishna sir and all the team, Sanjeev sir and everybody, for organizing such a wonderful conference. And thank you very much.
Thank you, Dr. Shanti. Dr. Shanti is one of our champions of newborn care from SNCU Vijayanagaram. She is a nodal officer there and has huge experience of saving preterm newborns. And thank you, Dr. Shanti, and continue the good work there. Madam Rajeshwari, madam, a few words from you.
Yes, yes, sir. Yes, sir. Good evening to one and all present over here. Really, it was a nice interaction session, sir. And from TNA side, I want to thank the complete team, Sri Krishna sir and others, who has organized this one, KMC, because as like it's a component, the component what we learned today, like the practical demonstration part, like we were only reading in the books and seeing the video, but Himabindu madam has clearly demonstrated, and it was really very nice to have the session. And and one more thing, like I want to thank, because the nurses, you have included the nurses. The nursing fraternity, you are giving an opportunity to learn, to participate in like these workshops, and I request you to organize some more workshops for our nursing fraternity, sir. Thank you once again for organizing this workshop.
Thank you, madam. Thank you.
And giving us the chance.
Thank you. Newborn care is by a team, and nurses are the backbone. It's called rightly a nursery. And it's the doctors who are helping the nurses implement it. So I totally echo your sentiments, and all programs so far have always been as a team. You have a DM neonatologist participating, as well as a young nurse who's again part of the same team, and all our efforts are for the same goal of trying to save newborns. May I now request a few comments
sir,
from
one more thing, like,
yes, ma'am.
Sir, like I was planning to have a workshop same like this to awareness. I think because as Nikhil sir was telling in the community, if we have teach them, I think if we go for community step and arrange for the ANMs, I think we can do some more better work. Because the follow up and all those people has to do in the community. So I think we will try to arrange one workshop for them also, sir. I think that
Thank
will
you,
be
ma'am.
better.
We'll definitely take it, and I'll convey this to Dr. Karor, Dr. Shashivani, and the team.
Yeah.
Dr. Rajeshwari is the president of the Trained Nurses Association of India, the Telangana state chapter, and we have done a lot of activities for nurses exclusively. And of course, as I've said, they're always part of the pediatric team, and we do it together at all our newborn units. Dr. Ashish, for your comments, please.
Yeah, Dr. Krishna, it was a great experience. Basically, in spite of some limitation of virtual meeting, you have done workshop. You have conducted it very nicely. The 3-room concept was really very innovative. At least I have come across for the first time, and went very well. I must say that I joined halfway, but really I enjoyed the last session. Thank you very much.
Thank you, sir. Thank you. Request some of the faculty, Himabindu madam and Vijay Kumar sir. How was that? I know you've been part of all this for so long. Request you to please share your thoughts on the experience of doing it.
Yeah, thank you, Sri Krishna. It was amazing, wonderful experience, as usual, with you. And KMC is very close to my heart. And love to see Dr. Shashivani also joining us, Dr. Nikhil, Dr. Aditya, Dr. Suman, Dr. Somashekar, Dr. Vijay Kumar, our colleague from Varangal. Then, of course, we have Satish from Vizag, Ramesh from Jaipur. Nice to be one amongst you. Dr. Ashish Mehta. Ji, very good afternoon and namaskars to all of you. Madam Shashivani ji, thank you for initiating this in our country. I know that how you've seen her closely over last decade, how she was very pursuantly behind this. And we all understand actually working in medical colleges, both in public and private sector, especially in the public sector, we have seen huge dividends of this very simple, cost-effective procedure of KMC. So we have been talking for a long time, but actual implementation was, I think, through UNICEF has really backed this and taken this as a huge mission to see that the KMC wards are established and their dedicated staff and a space being created in every SNCU. And Telangana, we have taken lead and we have our own success stories, number of babies coming out and early discharge happening, very satisfying experience for the mothers. And actually, when Sri Krishna told me do virtually with just dolls and mannequins, I was thinking, let me go down and actually show them a real experience in the KMC ward with in the government sector, of course, with a huge turnover here at Nilofer, 300 newborns being here, and the premature at the SNCU, we cater basically to the inborn babies. Lot of huge burden of low birth weight babies with us. And we have very good success stories coming out due to KMC. Thank you, Dr.
Thank you, and it was
so
very
much.
nice that people across the country were able to see the KMC ward at Nilafar Hospital.
Thank you.
Sometimes technology has its own benefits as
Yeah,
well. Last remarks from Vijay Kumar sir, and then I'll hand it over back to KMCF team.
Sri Krishna sir, again, there are so many dignitaries. I don't want to name everyone and this thing. The breakout sessions are really learning experience. The first one, there was a little technical stack regarding with Yadaya sir, and this was the second one. I had a very stranger co-facilitator with me, or rather, I was learning. Rekha Udani Madam ways, and third session I was with my participants. So each breakout session is a real learning experience. I thought we'll go on this. And about regarding QI projects, I thought we are in a mood and a stage to increase our number of QI workshops. Thank you very much, Sri Krishna.
Thank you. So that's all from our end. I hand it over to Dr. Somsekhar. Would love to hear from you, Dr. Somsekhar, Dr. Rekha Udani ma'am, Dr. Suman Rao, and of course, final words from Shashivani madam herself. Over to you, Somsekhar sir.
Good afternoon, everyone. I thoroughly enjoyed the meeting, and I was seeing a lot of interaction that was there, and I think this has been especially good, the breakout rooms and people rotating through the rooms. I think Dr. Sri Krishna, you have done a wonderful job of using technology to make us feel as if we are in the same room. So this is especially useful, and I'm sure we'll all learn from this, and we'll ensure that we continue to do this in our wards as we go back to our rooms. I am especially thankful to Dr. Rekha Udani madam and other senior faculty members who joined and express their happiness at the way in which the course is being conducted. With this, I think I'll hand over to Dr. Kharut first, and then Dr. Shashivani, and Dr. Suman, and then Dr. Shashivani. Dr. Kharut, can you please say a few words about today?
No, I think I have mentioned whatever I wanted to. The experience was very exciting. The breakout room and all that. That was my learning from today's workshop. So I think we have to think about such ways, in time to come, because we are going to face this problem for a long time, and the academic activities have to go on somehow. So this was a very good experience for me, and I'm very happy that generally the speakers they stuck to the time and they presented well. So all in all, it was very good and interactive.
Thank you, sir. Dr. Suman, can you?
Good evening. It's such a pleasure to be with you all. Unfortunately, I missed a big part of it because we were preparing for tomorrow and the coming conference. But I know it went off to a fantastic start, and they always say that well begun is half done. So thank you to UNICEF and Dr. Sri Krishna for this wonderful beginning for the 5th National Conference of Kangaroo Mother Care. And I take this opportunity to welcome each of you all for the main conference. And we have a big spread of lectures and discussions for you all. And we have also tried to benefit from this pandemic and this virtual conference in the sense that we have got the best across the world for this conference. So I do invite each of you all to participate in that. And thank you, Dr. Sri Krishna, for a wonderful beginning. Over to you, madam, for the final words.
First of all, I thank Sri Krishna and all the team members to have conducted such a wonderful session. When we decided about this session itself, I never had any doubt about it. So I never questioned how you are going to organize, what you are going to do. And today we are seeing the fruits. Unfortunately, I have missed learning many things here. Technically, I am very, very backward. So here, I should have learned many things but unfortunately I have missed the opportunity. But whatever few words we are hearing at the end from the participants, I feel all the efforts were worth. And I would request Sri Krishna to teach us all these new techniques also, so that we can also improve our things. So QI component we can also involve in our setup. And again, I thank all the faculty members, all the participants who have shared their valuable time for this topic. And finally, one special request. We are all been talking about kangaroo mother care, but unless it is practiced with good quality and reaches to minimum of 90% of the eligible population, we will not see the impact. My worry is this, that everybody will say, yes, kangaroo care is good. But in the national level, if the impact has to be felt, minimum of 90% coverage with good quality of kangaroo mother care, which includes promotion of breastfeeding as much as possible, planned early discharge, regular follow-up, and early development, and all the components, we will not see the impact. And probably someday, if we do not do the practice well, there might be a stage of disillusionment, which we do not want. So I request each and every member here who are convinced with kangaroo mother care and now who are competent to practice it, share these messages to others and make others not only know about it, but make them competent to practice it, so that the message spreads everywhere, and it should become a part of the routine. It should not be considered something different, something special, something. So just as the baby is born and the cord is cut and the baby is put to breast, kangaroo mother care also should start with early skin-to-skin contact, prolonged skin-to-skin contact, continued as kangaroo mother care, and especially for the preterm and low birth weight babies, it is continued for a long time. So right from the term babies, it has to be done. It can be done even during transport. It can be done even during baby care. Even for the sick babies also, you can do it. So please try to take up all these messages and improve your thing. And I once again thank Dr. Sri Krishna for taking up this project so well and conducting. And thank all the members who have participated and who have been the faculty members who have spared their valuable time. And on behalf of Kangaroo Mother Care Foundation, I express my sincere gratitude. And as Dr. Suman has rightly said, they have put in a lot of efforts to organize a very good conference and inviting so many international illuminaries in this subject also, which otherwise we would not have had an opportunity to listen to them. So all of you take this advantage. And we have made it quite free also. As much as possible, all the benefits have been passed on to the participants. So we request each and every one of you to participate in 2 days conference and make the maximum benefit. Thank you very much.
Thank you, ma'am. And thank you for all the support from KMC Foundation and the entire organizing team. As you have rightly said, it's the trust and the belief that you have that Sri Krishna will deliver. And thank you. That gives me a lot of confidence to get the best of people and do a session. We've been able to exactly finish at 5 p.m. and it's just some complimentary remarks that we are having right now. Thank you. Thank you for all the support, guidance, and the cooperation. Dr. Sanjeev, if you're around, a few remarks and then we can close this workshop.
I must thank, special thanks to UNICEF for all the support.
Dr. Sanjeev. All right. So conveying thanks from the UNICEF Hyderabad field office, the entire team, and thank you for all the efforts put in. And a big thanks to all the participants. And it was really tough to close registrations within just 5 hours of opening. And I was very confident, and I was telling Suman ma'am, we're going to have a full house, and it's going to be very exciting. And thank you. It's everyone's participation that made a difference. So before I finish, I have to show you whether we really did justice in this workshop. Hope you all can see the poll results. So 92% who can perform KMC, all of them. That's right. So that session went on well. Which of these is not a part of KMC position? 92% saying extended limbs is not. Again, thank you. Which of the following is used for developmental screening? You use all of them, but if it is specific for development, you use TDS chart. Which of the following is a part of the definition? All the above. And what are the components of good quality KMC? 94% say all the above. Thank you. So this implies that this gives us confidence and also some job satisfaction for the faculty. Excellent work, and it's been a pleasure interacting with the faculty, coordinating with the organizing team, and conducting this workshop. Thank you. I'll be sharing a small feedback form in the group. Request you all to fill it up and share it with us so that we can make these workshops much better in the days to come. Thanks, everyone. You can now leave the meeting.
Thank you.
Thank you, sir.
Thank you so much. Thank you. Madam Shashi